I want to welcome everybody, especially Jim Hauser. Congratulations on your retirement. It's very exciting. I don't know if those outside the metro area saw there was a great article in the Oregonian about the work that Jim and his wife have done at their business, and it kind of goes well above and beyond just running a successful business for many years. It was really inspiring, and if anybody wants to see it, let me know. Jim's probably too modest, but it's really a heartwarming story, Jim, and I just wanted to acknowledge that. Congratulations, and
Thank you.
We're glad you're still with us.
Yeah.
You didn't retire from the committee, which is great.
Actually, I'm coming back to the committee.
Yes,
Yeah.
great.
Just
Good.
with a different hat.
We're going to give you some additional assignments because now you have more time on your hands.
I've gotten those phone calls too from Tax Fairness Oregon, from Family Forward.
So what we're going to do, folks, is we're going to approve the minutes. I don't see any new faces here, so we won't go around and do introductions, but we're going to approve the minutes, and then we're going to juggle the agenda a little bit. We have some elected officials due here. And then I think what we'll do is we'll ask Cable, we'll jump down to midway on the agenda on the second page. We'll ask Cable to go, and then Cable, I will ask you, if Representative Salinas does come in, we might ask you to pause. Let her go, and then but we'll give you whatever time you need to finish your presentation. So let's start. Does anybody have any comments on the minutes? Oh, sorry, yes. Is there anybody on the phone with us? Okay. Nobody on the phone? So because we don't have anybody on the phone, we actually don't quite have a quorum yet. So we're actually going to hold off on approval of the minutes. And what we'll do is I think the agenda is self-explanatory. We'll move right to Cable, who's in the 135 spot. I'll ask you to start. And again, if I see Representative Salinas come in, I'll wave my hand at you and we'll take a pause.
Sounds good. Okay.
So Cable, introduce yourself and let us know your topic.
Cable Hogue, the implementation analyst and federal liaison for the marketplace, which means I interact with CMS quite frequently on all sorts of matters, and one of those is our data for enrollments, whether that's through open enrollment or throughout the year for special enrollment periods. So I'm going to go over the 2020 open enrollment plan selection data. I should start by saying CMS embargoes the data that we're able to share and confines it to what they've shared publicly. Publicly, the only number that they've shared is the overall plan selections. So what I'm going to do with that being said is I'll give you some percentage differences over the previous year so that you can kind of understand where we were compared to last year. And then in March, when they release the full data set, we can get into more specific details. So with that being said, here we go. So overall plan selections for 2020 open enrollment were 145,264. That's about a 2% decrease from last year's 148,000 plan selections. Given all that's gone on with the administration and other factors like lower unemployment, that's not a very significant decrease, so holding fairly steady with the plan selections. In February, we'll have our first release of actual effectuated enrollment data for January. So that'll give us a better idea of what we're looking at for actual enrollees who effectuated and paid their premium on their plan. Typically, it's not the full 100%. Go ahead.
I think you're about to answer what I was going to ask you, so
Yeah.
I'll let you keep going.
Oh, yeah. Typically, we see about an 85 to 92% effectuation rate, depending on the plan selections from an open enrollment. We're usually in the 135 to 140,000 effectuated policy level. And again, we'll have that information in February to share. Auto re-enrollment, so the folks who passively let their plan re-enroll without making any changes, let the system handle it, was up 10% from the previous year. So that usually means that those folks were pretty happy with the plan they were in, might have browsed the plans that were available for 2020 and just decided to let it passively re-enroll for them because they were satisfied with the plan. New consumers. So the amount of unique consumers who are either individuals who have not selected a QHP with coverage where it did not go all the way through to 2019, or folks who selected a plan but didn't effectuate it. Those are what's considered new consumers by healthcare.gov standards. That was down 8% compared to the previous year. Returning consumers with an active plan selection. So those were folks who would have auto re-enrolled, but then went in and decided to actually change the plan that they were enrolled in from the previous year. That was also down 3%. We also saw, and this is somewhat unusual, this is kind of the first year that's happened, we saw a slight decrease in plan selections, the share of plan selections with APTC, so a 2.7% decrease in that. There could be some factors in that outside of our control, like the calculation CMS uses for tax credits changed a bit this year. So the actual amount of people that got tax credits could have changed, or that were eligible for tax credits could have changed, as well as in a couple counties, the second lowest cost silver plan changed this year, and that could lower folks potentially getting APTC as well. So if we had more access to data and could see at the plan level and at the actual consumer level what people were doing, we would have a better idea if that was the case or not. But at this point, it's just kind of speculation that those two factors could have led to that decrease. There was a 3.1% decrease in share of plan selections with CSR, so cost sharing reductions. Again, a number of factors can go into that. Folks might elect to get a bronze plan if they're lower users of health coverage and want to save the monthly premium, or folks who are higher users but on a very limited amount of cost sharing reductions might choose to go with a gold plan if they think that fits them best. So that's kind of where that could happen, and I think the numbers for actual share of bronze plan and gold plan selections kind of support that theory. We saw a 3.6% increase in share of bronze plan selections this year. We saw a 2.3% increase in share of gold plan selections, and we saw almost a 6% decrease in the share of silver plan selections. So that kind of bears out that the folks that are on those fringe cost sharing might be electing to go for a lower premium bronze plan or a more rich gold plan, depending on their health needs. I have some other information if people have specific questions. That's kind of the high level, what we were looking at. And
Questions from Cable, questions from the group?
Go ahead.
I'm interested in some year-over-year themes that you might have picked up. I know you're presenting one-year data.
Mm-hmm.
There we are. So let's pause right there.
Yes.
Let's welcome Representative Salinas.
Yeah.
Come on in and please sit. We were just getting an open enrollment update from the team.
Oh, great.
Yeah, and that kind of is the formal presentation portion there. So if folks have questions
Yeah.
later, we can wait till later.
So later in the agenda, we'll give people a chance to think about questions. And in the meantime, we'll welcome State Representative Andrea Salinas.
Well, thank you. I was actually, I think, looking at your press release from just post finishing up of open enrollment, and I know we're down a couple of %, but the fact that we're still pretty close and our numbers are still high is a good thing. And I thought, we didn't have you guys come before healthcare, but we'll have you come at some point.
One of the things we're cognizant of, so this is the Marketplace Advisory Committee,
Yes.
you know that. We're cognizant of our accountability is to keep the marketplace running to support the team and DCBS. But we also understand we operate in a larger ecosystem.
That's right.
Designed by the legislature and meant to provide coverage to as many Oregonians as possible. So one of the things we always save a little bit of time to discuss is how does the marketplace and what we're doing to support the marketplace stay consistent with the larger vision that you and your colleagues have for Oregon health insurance coverage. And wanted to have you here just kind of open-ended to give us a sense of what's on your mind, what your priorities are, and how the marketplace and the Marketplace Advisory Committee can be supportive.
Well, thank you. Thank you for having me here today. So as some of you know, I'm State Representative Andrea Salinas. I represent House District 38, which is Lake Oswego in Southwest Portland, and I serve as the chair of the House Healthcare Committee, and I've been serving in that capacity since about I don't know, 11/21 on February 21st of 2019. So
who's
not
counting?
quite a year. Not that it's traumatizing or anything, but no, it's fun. And I also serve on the behavioral health it's now a full committee through the interim. See if it stays that way, Behavioral Health Care Committee. The Human Services Subcommittee, and then I also serve on the Public Employees Benefit Board. So I was at the Oregon Health Forum yesterday, and the things that I actually discussed were kind of bigger picture items, because I think we've done a lot around healthcare over the last couple of years, and you all have been part of some of the big changes. We did Cover All Kids, reproductive health equity. We're asking, I think, a lot of our health plans to do more, right? And we're covering more, and these questions about coverage and benefits keep coming up, and who do we cover and that sort of thing. But at the same time, we've also been asking our plans to control costs, and what does that look like, and how do we get there? And so, and also our pharmaceuticals and our hospitals. So we're asking everybody, I think, right now to pitch in and to figure out how we get our arms around continuing the march toward real transformation, so that triple bottom line. And I think cost containment is kind of the big thing right now. So I know some of you may be participating right now in the benchmarking discussion, SB 889. And this is kind of what I told the folks at the Oregon Health Forum yesterday, was really look at some of the things that we're doing, some of the rulemaking in these areas around cost control. So 889, I know, is a big discussion. And this is an area where I think you all can help us figure this out as well. And then I'll get to the fun piece where I think we have more options. But when I was last week, when I was listening in on Jeremy's 889 kind of update, he mentioned that nearly a third of a family's total income goes towards premiums now. That's a lot, and that's not sustainable. And so we really do have to figure out this, this cost containment issue. So I think, finding the benchmark and then finding the right mechanisms around enforcing the benchmark throughout our healthcare delivery system will be an important piece that we bring back in 21. So what I'm basically saying right now is I don't know that you'll see a lot for the short session, but kind of let's start setting the groundwork. And we have a lot of work groups and task forces going on that I think will come back in 21 and see some bigger legislation again. We have the hospital charity care and community benefit work that's also going on. So trying to figure out what the right floor is for hospital spending around hospital charity care and community benefit. We also have some prescription drug bills that we have that are being challenged right now by the pharmaceutical companies, but trying to control those costs. And then the governor has, and then the kind of the next big thing on the horizon is behavioral health care, right? How do we start to integrate behavioral health care with primary care? So how do our provider networks look, and how do we make sure that folks have access in a meaningful way, knowing that we don't even really have an adequate workforce at this point? So I'll be working on a behavioral health care workforce bill that looks at all of the, because there's a lot out there, a lot of studies that the Behavioral Health Collaborative has done. The Health Policy Board is looking at this issue. But really starting from the ground floor and foundationally, can OHA bring me back some suggestions for the most meaningful impact for behavioral health care workforce, which I believe may be at the community healthcare workforce area, so peer support, community health workers, that sort of thing. And then how do we start to build as we go up the scale for the more expensive levels of care and different acuity? But not only just in the Portland region, obviously, but across the state. And where are we missing some workforce pieces? So if OHA can bring me a study back before 21, I think I'll have a clearer idea. And then I know the Senate Mental Health Committee is also working on some pieces around severe and persistent mental illness, as well as the governor's Behavioral Health Care Advisory Council. So this will be something that's very big and kind of, I think, hopefully, again, if we're in good financial shape, we'll see some new spending, or at least new spending requests in 2021. But really trying to figure out also how we fit it into, because we know we're spending a lot of money in behavioral health care, we just don't know if it's in the right places. And then how do we integrate that with our current system to make sure that patient access is real on the ground. So those, and then just a couple of bills that I'll mention that I am working on that are just kind of shorter term. So kind of continuing down the path of containing costs. We've heard from some of our insurance partners that dialysis centers charge a lot in private insurance for premiums when we know that dialysis patients, once you hit end-stage renal disease, you can go on to Medicare. And but the cost, I think, for the treatments is about $247 a treatment. Yet they're reaping about, I think, $250,000 in profit every year from a single patient. So we know that they're making about close to $2 billion a year in profit. And I started, when it hit me, I didn't realize Fresenius was a German company. They have caps in Germany on dialysis treatment. It feels very much like the pharmaceutical companies, right? Why should the U.S. be the one subsidizing for caps someplace else, for price caps someplace else? So I'm going to take another shot at this, see if we can get this done this session, because again, I think we have bigger work to do heading in the out years. So I'll save the best for last. We have a bill, it was SB 770, also in a task force form to figure out, is there a way for the state of Oregon to get to universal access to care? And I like that term. I like universal access to care. I also have been avoiding saying single payer. I've been saying payer reform. I said it at the DPO summit. I've been saying it in front of all kinds of folks. Because I think what we're trying to achieve, and I'm totally agnostic in terms of who the payer is, right? I don't really care as long as the patient experience can feel the same everywhere, right? So and the metrics, right? Are the metrics similar? Are we using value-based payment? Are we, again, going towards that triple bottom line? So 770, great. There's a task force there. We'll see what they come up with. But within that, there was one small piece where I asked OHA, and I think, Jeremy, you're working on this as well. Jeremy got a lot of the work that I think I passed out of, at least for my personal bills this past session.
Job security.
Yeah, exactly.
Maybe.
There's no collusion here.
Maybe.
So I've asked for them to come back to work with a contractor. Have you guys let the RFP yet, or?
We did just last week. We haven't announced it yet.
Okay.
We're still doing some negotiations.
So trying to figure out, is there a public option for Oregon? Is there a path for a public option that makes sense? So, and then whether it should be put under, and I had been calling it Medicaid-like buy-in. I think really I'm searching for Medicaid benefits. And again, whether it's within the CCOs or in the exchange, I'm agnostic. I want people to be able to retrieve any subsidies, though. So that would be my biggest, I think, hope for that. And then again, really trying to target that last 6% and those who are underinsured as well. So uninsured and underinsured, because again, that third, 1/3 of household income going towards premium feels like a lot, and we keep hearing it, and from our smaller businesses too. So, and as I had just been having a conversation with somebody from OHA, it's very bipartisan, right? I think we are all trying to achieve the same goals and outcomes. We're hearing it constantly from our constituents. So those are some areas where I would love feedback and help in trying to figure out where the exchange thinks it's headed. Oh, and then one thing that really excites me too is, and I've talked a little bit about, I think with Cheeky and some others from DCBS, is is the exchange able to figure out, is there a way that we can invest in its own platform? I think having been at the PEB board meeting earlier this week, I do think we're in this little short window where investments maybe need to start being made over the next couple of years, like real investments, if we're going to start to see some longer term outcomes in some different areas. And a platform for our own exchange could be one of them. So to help, again, achieve some of these goals that we have on a larger context. Is what I said, did that make sense? Like, are folks understanding what's in my head? Because sometimes I feel like I don't articulate it very well. And I still feel so relatively new to healthcare, and certainly to the behavioral healthcare world. So with that, I'm willing to have dialogue and, take questions.
Yeah, let's open it up to questions. I know your very last point resonated with all of us because we've done a ton of work as a committee around the platform, and we're ready to be a good partner to the legislature and the governor on that.
Awesome.
Eager to get moving on it. In fact, there's a lot of interest. But let's turn it open to questions on any topic that Representative Salinas covered.
And I'm getting my assignments later today. In fact, I think the speaker just sent them across my desk, so those should be coming out soon. So, but we have well, I said we don't have, I don't expect a lot in healthcare. I think I'll have about, 15 to 20 bills.
I'll start us off with one.
Yeah.
Representative Salinas, you mentioned that we have about a 94% coverage rate, 6% uninsured, and you're focused on extending access to those. The purpose of the public option with the Medicaid buy-in potentially or Medicaid benefits, is that primarily to address those 6%, or is that to address the cost issues that you referenced that apply to all of us?
I think both. I think the uninsured, but also the underinsured. So those that are finding it hard to actually stay insured because of cost. In addition to, that population who just, and I think this may be part of it. I had a bill last session that also included the shared responsibility, given what the feds have done. So, do we put something like that back in place? I didn't want to fight over it last session, knowing that I didn't really have kind of a public option in mind to go with. So I'd be willing to bring it back this session if you think that, because I would hate to continue to slide back on our coverage, right? And I know, and I get hit from both sides. It's not about coverage, but right now the system that we're in, it is about coverage, right? People do need some type of insurance in order to access that care. So I would hate to slide back anymore. And so I don't know, and I wanted to ask all of you, why have we slid back a couple percentage points on insured? Is it cost? Is it the mandate, the shared responsibility mandate was lifted? Is it public charge? What are you sensing, or what does the data show us?
So that's a great question, Representative Salinas. So the data, we currently don't have direct access to the data as to where folks are going. If they leave the market, for example, for the marketplace side, if they leave marketplace coverage, where do they go? We don't know that information. My only hope is that they are either going to Medicaid or getting some job-sponsored coverage, or even to Medicare, that they're going somewhere. But whether or not we can track them, that is the big question that we always have year over year. So anecdotally, we can all speculate as to why, for example, in our enrollments in the exchange, 2% decrease from last year. And previous to that, 5% decrease from the year before. So we were growing steadily until last year, and then it started going down. And federal uncertainty is always one of the top responses that we get from our stakeholders or when we speak to other state exchanges. We also heard that because of the zeroing out of the mandate or the penalty is also a consideration, as well as all the different things that, federal uncertainty, Texas versus Azar, the threat to CSRs. Public charge has also been brought up, whether or not there is a direct impact to marketplace enrollees, but there is always a chilling effect that we are always watching out for. Do we have data to track all of these speculations? Unfortunately, we do not. Okay. But we just hear from the community, we just hear from the other exchangers, other health policy folks, and these are just some of the ideas that they've thrown out there.
Great, thank you.
Jeremy, I wonder if the surveys that you've been involved in prior years have shown where things have gone up.
Where folks have gone.
Yeah.
So we have, every 2 years, we do the health insurance survey. We have the latest results, but we are still in the process of sort of slicing and dicing it.
Right.
And so we'll have some better information in terms of, race, ethnicity changes, in terms of where people got coverage. Folks are indicating that it's too expensive, things like that. We're still sort of slicing that. What we did see was overall the rate stayed about the same at 94%. This is before this last open enrollment period, so it doesn't include changes this last few months. But overall, the overall number stayed pretty steady. Individual dropped a little bit, group increased a little bit. Everything else pretty much stayed the same. But again, that's kind of already almost outdated because it was survey last summer that was in the field.
Right. Yeah. No. And I know you brought some of that data to the Universal Access to Care work group when I was chairing that, and and there's a big population still out there too that does qualify for Medicaid that we're not capturing. So I had wanted, that was the piece of the shared responsibility mandate that I wanted to implement, and with the penalty, and then I thought we could use some of those funds to try to actually do some outreach and enrollment on the Medicaid side. So. But I'm willing to listen to other ideas too.
And Chicky, I don't know if you wanted to talk at all about the focus groups or polling you guys had done last year, but there's at least some good anecdotal information in there around folks saying, premiums have gotten to the point, deductibles have gotten to the point where it's cheaper for me to pay penalties, it's cheaper for me just to pay for a doctor's visit out of out of pocket than try to pay a premium that's not even going to cover the cost of that.
And so I think you summarized it really well. So it really depends on the demographic. Our young and healthy opt to not have coverage for a variety of different reasons. I'm looking to the rest of the team if they've heard of other information about where the folks are going, why folks are choosing to be uninsured or underinsured. So these are broad themes.
Yeah.
I do know that for our state, our consumers are very grateful about the Oregon Reinsurance Program because that really helps lower rates. So instead of 14% increases, the reinsurance program helps lower by 6%. So instead of a 14% increase, we get 6 to 7%. So that's a huge benefit to the state, and we hope to be able to continue that for years to come because premiums will always be a big selling factor or non-selling factor, if
Right.
you will.
And I just want to mention Andrew Stolfi joined us, Representative Salinas. You might not have seen him, but Andrew, you're welcome to jump in if you have any data or anecdotal or otherwise about changes that we're experiencing in the marketplace. We've covered a lot of different themes, but just want to make sure if you want to weigh in, you can do that. We also have people who work directly with consumers. I keep looking at Shannon because she's out there every day talking to people about the cost of healthcare, and I'm curious what you hear.
I think just echoing what everybody has said. In my own just anecdotal, so the demographic that I work with, I represent Wasco County and Hood River County. I've had individuals who 5-6 years ago dropped their small group plan to jump into the individual market are now coming back saying, well, I want to get back into the small group market because rates seem to be a little bit more stable, plan designs are more robust, so that's been nice, but obviously would represent a decrease in the exchange.
Right.
We had one carrier in our area, Regents, who hadn't been competitive, who does not operate in the marketplace, and I had some folks jump out of the marketplace who are unsubsidized and go with Regents as a carrier, still insured, but just switching to a different carrier. A few people, because of the penalty, chose to not continue insurance, but I didn't really see that be a big factor. A lot of folks who have been purchasing now see the benefit of insurance and want to continue to purchase.
Okay.
I've had a handful, too, of my unsubsidized clients, so 400% or higher, who went with the short term or the health sharing plans. Not with my saying please don't, but they did.
Yeah.
So just for cost reasons too. But other than that, I think things have been fairly stable, and just kind of echoing what everybody else has cited. So.
Okay, that's helpful. Thank you.
Anybody on the phone, if there's anybody there who has questions for Representative Salinas, I want to make sure we give people on the opportunity. Nobody there. Okay. Other questions? We're going to transition to the panel, but I want to be sensitive to your time. Other questions while we have Representative Salinas here? We appreciate your investment in these issues and your expertise and your leadership on the committee. And
Oh, thank you.
absolutely.
And likewise, thank you all for serving in this capacity.
We're going to have, and I know you won't be here, we're going to have later on our agenda this afternoon, we're going to have a discussion about the platform and the work that we've done around the transition off of a federally facilitated marketplace. If you have any additional comments, one of the things we're watching on the marketplace is a lot of other states making that move.
Right.
The technology clearly has improved. There's better functionality, lower cost. I mean, all the stars kind of line up around that, but there are some political considerations, I understand, as well to that. And so any other thoughts you have about how we can be constructive in that debate, we would appreciate your perspective.
Yeah, I mean, maybe just don't mention.
Anything.
You
It's
actually don't have to mention it, it's in people's minds.
It's a new day, right? I mean, we've learned, like you said, you've learned a lot. We have examples from other states now. I mean, it's been years. We're beyond that. So I am happy to help you.
Good.
And let me know if you have tools or ideas to think about this. But yeah, I've been thinking about this, the political ramifications. And I remember I think when even Cheeky and maybe Andrew, you guys came to me and I was like, oh, this will be easy. But no.
One of the things that struck us, we actually had hearings where we had, it was a year and a half ago, where we had people from other states talk to us about their experience. The staff did some great research and analysis, and there's a pretty compelling case around the increased functionality, lower cost, as I mentioned.
Right.
So our consensus, if I can speak for the group, seems to be it's our job to raise this issue, to be good stewards, to advise the governor and the legislature. We can't ultimately make the decision, but we want to bring it forward for a serious discussion.
Yeah, and I would too. And so whenever the time is right, I'd love to have you all at a hearing in the interim or at the end of February if we have any time.
Excellent.
Yeah.
We'll work towards that. Other final comments from the group? All right.
Great. Well, thank you.
Thank you so much for
thank you
making
again,
time.
and thank you for doing this good work.
Yeah, appreciate
We'll
your-
be in touch, I'm sure.
All right. So let's segue to our next panel. We'll welcome Andrew Stolfi, Tasha Sizemore, and Jesse O'Brien, all from the Department of Financial Regulation at DCBS. Andrew, do you want to just introduce the topic and dive right in?
Great. Thank you, Mr. Chair. So my name is Andrew Stolfi, the Administrator of DFR and State Insurance Commissioner. Jesse and Tasha are here. We were asked to talk about, at least I think we've got a bit of time, and the three topics that we were asked to talk about: the reinsurance program, 2021 rate setting, and short session. It won't take very long, so we'll kind of throw in a couple other things that are kind of top of our mind right now. I'll kick it off. Tasha will talk about a couple things, and Jesse about session. And we've got one of our own bills for short session, and a couple more that we're closely following. So it'll be busy for us. But I'll start with the reinsurance program you guys talked about. So really glad to say, I mean, Chiki mentioned the benefits of the program, 6% reduction in costs, which are great. 2020 is the third year the program's in effect. We were one of the first 3 states to get one up and running. Now, I think there's more than 10 states doing it. We've been consulted by, every state who came after us has reached out to us, and we very happily had discussions with them about how our program works and how we've structured it, and kind of how they could structure theirs. So 6% reduction in premiums. We just concluded, so one thing to keep in mind when you're thinking about the program is the time lag between when we have to make a commitment to the carriers to fund the reinsurance program to when the payments ultimately are made for the program. And we actually just finished the first year of the program, 2018. I'll tell you about how the timing works, and then tie this into maybe some future thoughts. So for the 2018 calendar year individual market premiums, there had to be a commitment during 2017, during the rate review process. It was a little strange the first year because we had just applied, and it wasn't until much later than a typical year that we got approval from the program and find out how much. But let's just say, during 2017, there was a commitment for a $90 million program funded with state and federal dollars, so in 2017, which affected rates in 2018. Last year, in 2019, carriers had until June 1, I believe, to kind of close the books on 2018 and give us all the data. We then did a whole bunch of data checks. We had auditors go on site to each of the companies during October and November to make sure. I mean, it's a requirement under federal law when you're paying out that much money. We would have done it anyway, just to make sure that the numbers are right. And then we issued checks. One company asked for a check. I think it was $40-something million. It's the largest check I'll ever have to sign in my life.
Goodness.
Yeah, and made those disbursements in December, and that closed. So that was December of 2019. Closed a process that began in 2017. So we just went through this for the 2020 plan year. It started earlier, so it was in around March or so when we said, here's how much money, and here are the program parameters for 2020. And again, it won't be until the end of 2021 when the payments are made. So a big time lag. We also, we estimate how much money we're going to get from the federal government. We just received our award, I'll say 2 weeks ago or so. Our 2020 award, which was $54.4 million, which is within a couple of dollars of what we got for the first year in 2018. For some reason, for 2019, it went down to $41.8 million. No idea why. It's this funny black box in DC where numbers go in and then something comes out. But glad it went back up to $54 million. The good thing there is, I mean, the more money we get from the federal government, the less state dollars we have to put in, which kind of lets us run the program longer. So there have been two bills passed to fund the program from a state perspective. In 2017, the program got off with a 1.5%, basically 2-year assessment. Last year, the legislature extended that for a number of years up to 2%. You know, we're going to have a discussion in probably 2 years about what to do with the reinsurance program. So he's talking about the future of it. Do we want to just continue that as long as we can and throw, you know, because every year it goes up. So 2018, it was a $90 million program. 2019, 95, 2020, 101 million. Every year it goes up just to, because as rates go up, if we want to keep a 6% reduction, we need to put more money in. So do we want to keep doing that for the foreseeable future? I mean, the benefits of the program are undeniable, 6% reduction, but as the market stabilizes, as rate increases become smaller and smaller from year to year, we're going to have to discuss whether we want to taper the program off, especially if we're unsure about the funding, continued funding after the couple more years. We certainly, you know, if there was no more funding, we'd certainly want to taper off the last 2 years of the program or so that it's not a 6% cliff, you know, after.
Can I ask you a question, Andrew? We have a number of people here that represent rural communities, and if I recall, one of the reasons that reinsurance was important in particular was to stabilize the smaller markets where a carrier, and we have some statewide carriers, a carrier might say, you know, it's relatively easy to do business along the I-5 corridor because there's critical mass, lots of lives, and the numbers work out. It's really difficult to go into a rural community as one carrier or one of two carriers. And so all of that background, just to refresh us, but to lead up to the question of, will we be able to analyze, you know, because we might have a different answer around reinsurance to stabilize, let's say, the Portland market versus reinsurance to stabilize the South Coast market or the Eastern Oregon market, where it's imperative that we have carriers willing to be in those smaller markets where one high-risk claim can really make the actuaries faint when they look at their experience in that community.
Yeah. Well, and I'd welcome Tasha, and we've got a statewide carrier, pretty much statewide carrier here to kind of perspective. You know, so it's certainly helped across the state. And we're separately exploring our geographic rating areas, and so there's a potential connection there about changing those geographic rating areas, how that can have a knock-on effect to the insurance program and how that operates. I'm not sure how granular the data is that we collect in geographic rating areas or in the different areas. If we could do that analysis, I'd welcome it.
So I think that we do have some level of data. However, it does take weekly and their analysis to get down to that granularity. I do know that I've seen some of the preliminary information that's coming out of the grant work that Commissioner Stolfi mentioned related to the geographic rating areas and ways that those can be better organized to address a larger population and bring those rates back down. I think that that's something that we heard from all of the carriers a few years ago, that those geographic rating areas were made in 1990 and didn't really keep up to date with population shifts and geographic and industry changes in Oregon where people were living. So that is definitely something that will be good to look at.
I have a question.
Go for it, Craig.
Well, maybe I'll comment. Yeah, I think it does help a carrier like MOTA consider being statewide. Just having that extra protection is very helpful to us. It's been a great program. You mentioned the funding, and I'm curious if, because it's both state and federal funding, is there one source that you're more concerned about than another, or both?
Well, it's a good question, Craig. I mean, they go together in a way, and not worried, but the state funding piece. So you have to have some state funding, and that obviously takes an act of the legislature to grant that. We've got 4 more years of funding, if I'm right, coming in. So, and it'll take, and we got that as part of the Medicaid, payment package, and also funding the reinsurance program. It'll take another act of the legislature. It'll take the commitment of the carriers to do this. It'll tie in, I'm sure, to the Medicaid program in some way. So I'm not saying worried about it, but it'll be most certainly an area in the next 2 years or so, 2 years from now or so, we'll have to start talking about.
Right. Maybe said another way is what's more, what we have to secure is state funding.
Yes.
As long as that's done, the federal funding.
Yes. As long as we have state funding, the federal will follow.
Yeah. And then maybe just based on the prior conversation, there might be another element beyond Medicaid with broadening access, whatever Senate Bill 770 does. Maybe that factors into this whole discussion.
Has there been any discussion at all about, I think about in the days of OMIP, the high-risk pool, and today with the reinsurance pool. The reinsurance pool is primarily a financial mechanism. Has there been any talk about perhaps seeding particular populations and looking at ways to better manage those populations or anything like that at the state level?
So, a few years ago, the division and the marketplace started looking at a high-risk pool, or there were several different options that were being floated around. One of them, namely, I spoke with Washington State on their high-risk pool. There are a number of challenges to doing that under the ACA structure, and it would really take some pretty significant changes to not just state law but federal law that's preventing that from happening at this time.
I'm chuckling because Representative Salinas mentioned the dialysis provider issue.
I was thinking about that.
Going to require special legislation. That all came to light in the context of the high-risk pool.
Although OMIP struggled with the dialysis providers as well.
No, exactly, yeah. That's where we all learned what a problem it was.
So I just wanted to follow. So Ken, are you talking about taking people and having them move to a different provider?
No, I'm not. Whether, almost the reinsurance pool, and this obviously takes some infrastructure to do, almost sort of from a reimbursement standpoint, pulls certain populations away and develops a...
Well, so maybe what you're getting at, so Alaska's reinsurance program is different from, I think, virtually everyone else, where, and a part of this maybe because they had until this year one carrier, but it's disease-specific based. So there's no attachment point coinsurance. Well, there might be a coinsurance, but it's for these conditions we will then reimburse. So it's reinsurance pool-like. And I wasn't here when we picked our model, but I'm sure that was debated. And
the high-risk pool,
yeah.
So you're talking about recreating a high-risk pool?
Maybe aspects of it.
Yeah.
Yeah, I mean, OMIP did direct people to one carrier, which was paid to administer. I mean, you guys remember that, and I think there's other ways to do it. You could leave people spread across carriers, but structure the reinsurance to look more like a high-risk pool rather than just a reinsurance model.
There's a little bit of that within the CCOs, right, where there's a couple of populations that are identified and arrangements are made, and everybody uses those arrangements.
Yeah. But so the federal risk adjustment program is also kind of meant to address this a bit. Yep. So it shifts money around if carriers get much unhealthier populations.
So
it's not perfect.
Just to bring this piece to a close, so what can we expect in terms of next steps on reinsurance? What are you and your team going to be looking at? I heard you say we have a couple of years to sort of decide how to extend, discontinue, modify.
Yeah. I think I wouldn't expect any changes for a year or 2 or 3. I mean, it's a kind of a well working machine right now. But what we'll have to do is figure out, all right, sufficiently far in advance of the end of the state funding piece, and I'm sure in conjunction with OHA and how that state funding funds the Medicaid program, have a discussion about whether that assessment will continue or not, increase, decrease, and then connected to that, where that money will go. Will it go just to OHA? Will it still go to fund a reinsurance program? Do we want a reinsurance program? All those questions we'll have to ask, but not for at least
Not for a while.
a year or two.
And to Ken's point, all that could get blown out of the water by Senate Bill 770 discussions and other things. Okay.
So it's that, and then so kind of while I'm here, I'll mention just 3 other things that are kind of top of our mind and we're working on right now. One, I wouldn't be surprised if you're talking about the Sustainable Healthcare Cost Growth Target Implementation Committee, if I got that name right. We've got 3 members right over there. I'm also a member of that, and the future of everything that we're going to have to do is all about controlling costs, and this work in that area is going to be one of the key ways that we're going to address that. One interesting aspect in connection to the marketplace and our role in the commercial market, and we spent half of the last meeting talking about this, is how that target is not directly related to premiums and premium growth. And intellectually it makes sense. We had a nice diagram that explains why exactly you do that and why that makes sense. It's going to take some explaining, I think, to consumers on the marketplace when they hear all this great work that's taking place to create a methodology and a target, and this is how much healthcare spending should grow, and if that's 3%, 3.2, whatever it is, and then their premiums go up 6%, 7%, how those two things have, quote, nothing to do with each other. And it'll take a lot of work between our 2 divisions to just explain that from a communications piece. The program integrity rule, if we'd be talking about this as well, requiring separate invoicing for non-hide abortion pieces. This is something that our divisions have been talking quite a bit about, starting outreach to some of the carriers to talk about how you're planning on this or thinking about it. We'll see if it goes into effect and when that would be. Would note that the final rule does contain a non-enforcement option for health insurance carriers. So carriers can choose not to terminate someone if they fail to pay the separate $1 payment. I think that's a great idea, and if it gets to a point where this rule is going to be coming into effect, that's something we'll certainly be having conversations with the carriers about. And then the last thing I mentioned, and Tasha might build on this, but standard plans for 2021. So we just started 2020, but we're already looking ahead to 2021. The standard plans, there's a rule advisory committee next week to talk about some options. We still need the notice of benefit and payment parameters to know exactly what the MOOPs will change and what it'll be and how the AV calculator will work, but we at least need to start those conversations. And not directly related to that, but we're literally in the first days of talking about this internally. Some of you may have seen Colorado passed a law last year, and Washington has at least introduced a lot of states around capping monthly out-of-pocket payments for insulin. So $100 per month, maximum out-of-pocket payment. That's something we're exploring, whether we have the authority to do, internally through rulemaking or something else, or if not, it could always wind up being a legislative concept. Would note that all the carriers in Colorado estimated the impact to be very negligible. So we'll want a lot of data to collect, a lot of analysis to do, but if that's something that we find would be a negligible impact on premium rates here, it'd be something we'd be very interested in exploring further. So that's it for me. With some questions, Tasha can jump in.
We do have a little bit of time, so questions, comments? Great.
Yeah, I had a question. I think AHIP was looking at value-based plan designs, maybe bringing them into the marketplace and I don't know exactly where that's going. So what I mean by that is lowering cost share for services that are deemed greater value, maybe raising it on things that are considered discretionary, maybe. I think OEB and PEB have those sorts of plan designs. So I'm just kind of curious what our standard plan designs, if that has crossed your minds or been thinking about that at all.
So I think that every time we go back to recreate not just the benchmark plan, but when we do the recreation of the benchmark plan, we also take a look at those standard plans and take a look under the hood at MRIs always come up as one of these, the value for what you're getting, those types of services. I don't think that we've ever gone as far into value-based services as maybe AHIP's thinking about, but it has been something between value-based services and reference-based pricing has also been something that has been discussed. Reference-based pricing more as just sort of like a theory for insurers to work with, because I do know that there are insurers out there, California PEB being sort of a model for that. In a way, some of the challenges with value-based pricing from a public policy standpoint that we've ran into in the past when we've been doing the essential health benefits in the standard plan is that everybody thinks that their condition and their treatment is equally as valuable. So getting the medical expertise in to talk about, I just read something online about x-rays and the iron, the aprons you wear for x-rays. Stuff like that is to start to kind of change public perception, like about efficacy in treatment.
So if I could just quickly say, so one of the states we're in is Montana, and Montana's had a fair amount of reference-based pricing work across the state. And unless there's teeth, in other words, unless there's ways to enforce that those prices will be accepted by providers, consumers get caught in the middle of it. So in Montana, we've avoided it because it's not a good arrangement with consumers if you're just setting a price that then providers then bill the difference to the members. So I think carefully about that.
And I want to mention something that Tasha mentioned, EHBs, just to remind folks, I think we've talked about this before, but we're going to be kicking off a stakeholder process around updating our EHBs and our benchmark plan. We're going to be kind of taking advantage of the new federal rules around this and the new methodologies to calculate kind of what's allowable. Some things we're most certainly going to look to incorporate. Illinois did this around MAT, so treatment for substance abuse disorders, making that part of the EHB package and updating it, and then kind of exploring what other changes can or should be made to keep within the, not the grace, but there's a threshold you can't exceed. Now, sorry?
The de minimis.
The de minimis, yeah. So we'll be looking to kind of update our EHBs and then possibly the benchmark plan to kind of continue to grow that.
Worth noting is that process is extremely lengthy, so it would be first updated for 2022 at the earliest.
Yes. And one last thing, Ken, looking at Ken, it reminded me, a lot of you probably know Rick Blackwell. He was our policy analyst. He was stolen by Ken.
Oh.
So he's unfortunately leaving DFR. Tomorrow will be his last day. So when you see him walking around, he will be wearing a different badge.
We can't deprogram him before he leaves.
Exactly.
Shannon has a question.
Yeah, I had a question about the changes to manufacturers' coupons with prescription drugs, and if the state's watching that, I wanted to hear from the carriers too. I'm concerned as a consumer, so we're having now our renewals for 2020 and having to let consumers and small groups know a coupon you used to hit your out-of-pocket maximum with isn't going to work anymore. And I'm really concerned that April or May or March, whenever consumers used to then having 100% coverage, they're not going to. And I don't know if the state's, watching that, if carriers are concerned or there's anything going on.
So there was a proposed federal change around this
Right.
that actually didn't wind up happening. And what the federal government was proposing is that they would only allow carriers to do that, to discount the coupons if it was for a brand name drug
right, and
with
there was
a
a generic alternative. Yeah, right.
But they walked that back
Right.
because of a bunch of technical considerations, and they may wind up doing something like that in the future. Oregon does not have any state law on this issue,
Yeah.
so the one thing we've instructed carriers is whatever you're doing around coupons, clearly explain it in your contract with your
So
members.
the carriers are saying that those coupons don't count at all towards the out-of-pocket max, regardless if it's for generic or if it's for a brand name. And I know not a lot, but a number of consumers have historically purchased HSA plans so they could hit that, with January or February prescriptions, and come March, they're still going to have a $6,000 bill. And I've seen the notices that the carriers do, and they're definitely there, but whether or not an average person reads that and understands it and then knows what's going to happen, I think are two totally different things. And I think consumers are going to be calling to complain or calling their doctor when they literally can't pick up their prescription at the pharmacy in March or April. And
we currently have no policy around this, but if people are having these problems, I think we want to hear so
what
that we
should
know.
people do? So I know they're going to have those problems. I know that people are going to call. As I'm doing my renewals with people, I'm letting them know what's going to happen, but there are a lot of folks who don't have somebody who's advocating for them, who are just going to go in May. They're used to, again, having 100% coverage, and they're not going to. So it just is what it is. But what should we do? Where should I tell customers to go to,
So, I think that the division has the prescription drug price transparency program where those complaints, or those not necessarily complaints, but those notifications to the division can come in about price changes.
Mm-hmm.
However, if there has been a change to the plan that the consumer was unaware of, that's an important call for them to make to the division so that the division can monitor that.
Okay.
So the things that can happen, just from my team. So I have my official title. I don't think the last time I was here I had my official title. So I'm Life and Health Program Manager now for the division, and my role encompasses both the product regulation side and the compliance and examination side for life and health. And so having those two teams together has allowed me to kind of take a broader look at things that we can do that moves issues out of back-end complaint reactionary to more front-end creative.
Yes. Mm-hmm.
And so the more of those kind of stories and information I can have, I can start to explore ways to work with carriers for better notifications. How can we get the information out there? What's prompting them to change the behavior? I can work with all of that information to develop a path going forward. And I can also, not that this would happen, but if there are coupons for drugs or conditions that are still being allowed through, kind of monitoring to make sure that that's not happening in a discriminatory manner, I think is going to be really important.
Okay.
Or that pharmacies aren't turning people away and not, allowing that to happen. The other thing that, for those emergency moments, I would hate to think that this would ever have to be used, but so that the prescriptions can get picked up, a lot of times local communities have
Right.
like all the
Medication
churches
assistance
band
programs.
together and
Yeah.
will pay for a pickup so that people can figure
Right.
stuff out.
I think those are going to be utilized, but heavily, and probably in a way that those programs don't
Deplete.
realize.
Yeah.
And so the resources are limited. I also feel a little concerned that this leads its way. There are a lot of consumer assistance programs that consumers use to hit their out-of-pocket maximum and then be able to still access coverage. And so will this change lead to potential other changes down the road in what counts towards a consumer's out-of-pocket responsibility and what doesn't? So,
Other questions, comments? So Andrew, I want to pose a political question to you. You can dodge it if you want, but I want to build on what Representative Salinas talked about. Seems to us that one of her big issues is the universal coverage discussion. Washington State passed a public option, as you know. I'm sure you're tracking that closely. Your agency is accountable for maintaining the integrity and stability of the current private market that sits alongside Medicaid. Those function separately but adjacent. Have you thought, and I know we're in uncharted territory here, have you thought about how your agency will work with the current private market if a public option comes on the radar as it has in Washington, maybe other states? I'm just really intrigued about your general thoughts as a regulator, as a policy leader, the current market. I know you probably won't be, taking sides and advocating in the legislature around this, but you still have to maintain the current market, regardless of what the legislature does with a public option or Medicaid buy-in. So, general open-ended question, but I think it's important that we understand the regulatory and the state leadership perspective on how to navigate the next couple of years.
Sure. It's a great question, and certainly won't weigh in on any opinions about which proposals might be best or better. But from the regulatory perspective, maybe the first thing I'd say is whatever happens, and there's a lot of different paths forward, it can't be sudden. It's not going to be. It's just impossible to flip a switch and go from our current system to a completely different system. So in kind of going through these discussions, the policy, the legislative debates, from the regulatory perspective, I want to make sure, one, everyone's interests are being heard, but two, whatever the process is kind of structured in a way that it can transition from what we are now to what it's going to be without leaving people behind and without disrupting the market. So we wouldn't want to see whatever the decision is causing carriers to leave the market and rates to quadruple for a 2-year process while everyone gets ready for something else. So everyone's going to have to be involved and everyone's going to have to participate. What exactly will happen, I think it's impossible to say because there's so many different proposals that all are kind of competing with each other in different ways and are mostly mutually exclusive. So I think it's going to have to be, we'll see where the momentum builds, we'll see kind of which direction the state starts to go in, and then we'll make sure that the transition is appropriate.
I can't speak to the political question, but just in terms of the conversations that are happening right now, there's a small work group of policy people from OHA and DCBS that have been meeting regularly to talk about the study and the recommendations that OHA is going to be tasked with making around a public option or Medicaid buy-in program. And from DFR, it's me. From the marketplace, Anthony Behrens is participating, and OHA has a few people involved. And there's so many different ways of designing a program like this that the impact on the commercial market and the marketplace could be really all over the place. And what Washington is doing is possibly the least disruptive version of this, where effectively it's just another commercial plan.
It's not even really a public option. I'm sure you've observed.
Yeah, the plan is designed by the insurance commissioner, and there's a reimbursement rate cap, but effectively, other than that, it's just another commercial plan, and it's in the individual market, and it's part of the same risk pool. So I think that would not necessarily be revolutionary if something like that happened here, but if it was a true Medicaid buy-in and it was outside the risk pool, it could have a really profound impact. So we'll be keeping an eye on it, definitely.
Dan, I would just add that, so process-wise, so we've got an internal team between OHA and DCBS, and they're trying to figure out how to hone in on a couple of ideas, and the goal is probably to bring back maybe 2 or 3 potential paths to the legislature in draft form in May, try to get some feedback both from them as well as public stakeholders over the summer and try to refine those. But, the path to trying to find something that's feasible and sustainable and not massively disruptive is going to be the challenge. And I'm glad that, folks like Jesse are going to help us figure it out. But that's our overall goal is we're bringing on a consultant to help is to sort of see if we can come up with 2 or 3. They might look very different paths that seem like the numbers might work out for the legislature to consider. Probably not to just say this is the one thing, unless it looks like there's only one viable path. But over the summer to get some feedback from folks, be able to refine that and finalize it before the legislature considers it in 2021.
Yeah, we all wear different hats here. We all have different opinions on the ideas that Representative Salinas was bringing. With our marketplace advisory hats on, I think we'd all agree the idea of minimizing disruption, maintaining stability, ensuring a smooth transition. Those are great values to bring to our work on the marketplace, regardless of where we fall on larger questions. Jim?
So I have kind of 2 questions. One is, are there other states that are also, have they stepped into what Washington's doing, what we're talking about doing? Are there places we can look that might be 1 or 2 years further ahead in this? And just a question on Washington State, because I haven't followed that. Will they be administering it through the current, however they're currently administering Medicaid, or will they be letting bids with private insurers? Has there any of that conversation?
I can answer both of those. So in terms of other states, the other state that's most active in this area is Colorado. They I think have not actually passed a plan, but they did a study with a recommendation. I think they're going to look at that this year. Washington is the furthest ahead state.
Okay. Yeah.
And a number of other states are watching Washington closely, I think. And in terms of how Washington is going to administer it, it's basically a bid for proposals to commercial carriers, so it's not administered through Medicaid at all.
Yeah, that's what I figured.
I think the RFP comes out in February.
Right.
We took you a little bit off track.
No, that's good. Do you want to move on now?
That's
Yeah.
good.
So, just a couple of things. So I was asked to talk about how rate review will look different next year. Well, I'd love to tell you, but we don't have the notice of benefit and payment parameters. What I can tell you is that we are planning on having the due dates for rate filings be consistent with what we have had them in past years, with the understanding with our internal actuaries and with the carriers and their actuaries that those dates are subject to change when CMS finally finalizes their dates. With the forms, we're going to try something a little bit unique. The draft timeline is currently circulating upstairs. We're considering moving the form filing deadline back to June. That traditionally has been much earlier than that, sometimes May, sometimes April. Our goal for moving it into June is to give carriers time to finalize what's going in their forms and to marry it closer with what is in their plan of benefits template so that there's less confusion as we're moving through the form filing process. And it's also just going to give our insurers staff a little bit more time to make sure everything is compliant before it gets to us. In other news related to the ACA and the plans coming out of that, I'm starting to work on standardized review questions for the form side. We've used standardized review questions on the rate side to answer some big policy questions in the past, and it's worked out quite well, and I'm going to be moving that in that direction on the forms and just generally trying to get a better understanding of the benefits. Typically, we use a multitude of data requests and data calls from our carriers throughout the year to get at the same information. And along with my theme of being a little bit more proactive that I mentioned earlier, getting that information and trying to work with carriers to resolve some of the concerns before they make it to consumers is one of my goals. Let me see what else. Andrew mentioned that tomorrow we are going to be having a TAG meeting that's called the Actuarial Group. It's where the division's actuaries and the carrier actuaries get together and discuss just kind of a variety of subjects. On the slate for tomorrow is the program integrity rule and what that will mean for the insurers and their bottom lines. and trying to also figure out how we're going to best help consumers understand this change, which I think is, in my chatting with the carriers, that's one of the biggest concerns is this is going to cause a lot of confusion for folks as they're paying their bills, and how do we reduce that confusion? Also on the agenda, and I think I have the bill number right, it's Senate Bill 526 that deals with in-home visits, yeah. So we've also been doing some work with coordinating a little bit with OHA around the in-home visits. We've been fielding a number of questions from insurers, so we're going to also give the actuaries a chance to weigh in on that tomorrow. Andrew also mentioned the cap on the insulin. We're going to ask that the carrier actuaries take a stab at what the actuarial impact of that would be tomorrow and get some data back for us by Monday. We're thinking that based on what Colorado said, Andrew said negligible, so the biggest lift may just be the toying with the AV of those plans. And then next Tuesday, I believe it is, will be the Rulemaking Advisory Committee on those standard plans to have a conversation to do the annual tweaks that we do to bring the maximum out-of-pocket and the AV back in alignment with federal law. I'm going to take a breath there and see if anybody has any questions. So I did want to talk really quickly about a non-Affordable Care Act, non-major medical thing. Next Friday at 2:00 p.m. in this room, the division's going to be hosting a long-term care insurance forum where we're going to be hosting some of our long-term care insurance companies and the Society of Actuaries to answer some questions about the history of long-term care insurance, the history of those rate increases, why they're important. We're going to have somebody from the Guarantee Association talk about rate increases versus relying on the Guarantee Association. And I invite all of you guys to come in person. If you have consumers who you spoke with, family members, this is definitely a time to come hear it from the insurers, come ask questions. If they're outside of the Salem area, we're going to be live streaming it. So you can also watch it live from the comfort of your own home with popcorn.
Questions, Natasha?
No, that's good. You guys, did you want to cover any legislation? You're going to do that?
That would
Okay.
be me.
So just a heads up, Jesse, part of our confusion is we're texting with Representative Kenny Geyer, who's going to join us from her car here in a few minutes. So maybe spend just a few minutes going on your bills, and then we'll transition to her, but you have the floor.
So, good afternoon, everyone. Some of you may have a dim recollection. I was once a member of this committee. It's always nice to be back. Heard from, at a high level from Representative Salinas about a number of the issues that they're looking at, but I thought I'd bring some specific legislative concepts to your attention. So DFR is one bill that we are proactively working on, came out of what we were calling our work group on alternatives to short-term health plans. Basically what this bill is designed to do, it's a pretty limited in scope, but we think it'll have an impact for consumers. It's designed to prevent people from falling through the cracks by accidentally missing a premium payment or getting a notice that is confusing, that they don't understand, and therefore not making a needed payment. So it does a few different things. So first of all, it extends for the outside the marketplace plans, the grace period for premium payment to 30 days from our current 10, which is very short. If this has no impact on the 3-month grace period for people who receive premium tax credits, but if you don't receive them, currently it's only 10 days, which is very short. We're also going to set up a 15-day grace period for the initial premium payment, the effectuation payment. Currently, there's nothing like that, and some carriers do it voluntarily, but we want to make sure that people have that. And then the final thing is that we want to do some rulemaking to make sure that people get better notices when they miss a needed premium payment. We've taken a look at some of the notices that are going out to people currently, and they're all over the map in terms of their quality, whether they are designed in a way that can potentially confuses people, and whether they actually contain all the information people need to. Is that the
I
representative?
just want, when you come to a break, I want to ask you guys to stay there if you can for a few more minutes, and then we'll hear from Representative Kenny Geyer.
The last thing the bill will do is give us the ability to write rules around what has to be in those notices. And we've worked this with stakeholders. It seems to be a consensus product at this point. So we hope it will pass without a lot of
Always the hope. You guys have other issues you want to stay there and come back to in a minute? Is that okay? Do you have time? Okay, I want to welcome Representative Alyssa Kenny Geyer. I believe she's on the phone right now.
I am.
Oh, terrific.
Yep. Can you hear me okay? Can you hear me okay?
We can hear you okay. What we want to do, Representative, is just give you the floor. A few minutes ago, we heard from Representative Salinas, who talked about some priorities for the legislative session around universal access, cost control, pharmaceuticals, behavioral health, et cetera. And we invite you to do the same and just tell us what your priorities are. One issue, of course, we have a special interest in is transitioning off a federally facilitated marketplace onto our own marketplace. So you have here the Marketplace Advisory Committee. We're around a table. This is our regularly scheduled meeting. And before I turn the floor over to you, I want to acknowledge that you've announced you're not running for re-election. So this is also our chance to thank you for your service. And
thank you.
To appreciate all that you've done over the last few years. And even though you won't be in the legislature next year, I think your perspective on healthcare issues is very important to us. And we invite any comments you want to make.
Okay, great. I assume I have maybe 5 minutes. Is that right?
You have whatever you need. 5 or 10 minutes would be perfect.
Okay, great. So, I just got out of a meeting with the new president of OHSU, catching him up on, my perspective on my approximately 9 years in the legislature, what I've fought for and what I hope for going forward. So, certainly the whole marketplace and the ACA expansion and the move toward more prevention are all things that I've watched developed over the years, and thank you all for your role in that. I am on the healthcare committee and I have a public health degree. My particular passion has been really around prevention and social determinants of health. And I go way back with Dan because I was on the Northwest Health Foundation board that had a big partnership with Kaiser to administer some of their community-based social determinants of health grants. So anyway, we go back. We have a strong affinity for those kinds of things. And the bills that I'm really focusing on as my primary objectives are ones that come out of my Human Services and Housing Committee. So it really comes out of the social determinants of health. There are things in the Healthcare Committee that I'm sure Andrea addressed, and there are other kind of related bills that will be in judiciary, other places like safe gun storage. So, almost everything that I touch on has some kind of health-related or social determinant of health-related aspect. But I did send Dan, and I'm hoping he can forward to your committee electronically or give handouts before the end of the day my top priorities. My 4 biggest priorities are focus on really trying to break the cycle of what I end up seeing in my committee in child welfare and chronically homeless as a result of our not really getting on top of mental health and addictions. And I'm sure you all know that we have one of the highest rates of addictions, and we have one of the lowest rates of access to mental health and addiction services. And I really feel that we've got to double down on that as a state and figure this out, both in terms of a coordinated system, resources, et cetera, because I keep seeing the result of it in terms of families that are on the street, people on the street, families who lose their kids to protective custody because of neglect. First year of a child's life is the highest year that kids are removed from the home for protective custody, and around 80-85% of that is because of addiction. So we have one of the highest numbers of kids in child welfare due to addiction, but proportionate to our population. So a lot of my bills try to get at this. One is a family treatment court bill that I believe is that we just got our bill assignment, and it did not come to me, so I am assuming that it went to judiciary, family treatment court, and so that's really beefing up the court system to allow kind of a designated track to a family treatment court judge who is knowledgeable in this area and refers people to treatment with wraparound services, keeping their kids with them whenever possible with parent ed and all that kind of stuff. So that is certainly related to healthcare in terms of the bill's not going to provide money for the addiction treatment itself. We hope that's going to be reimbursed by either private or public health insurance. But all the wraparound services and the court, and these are all best practices, and I have a lot of information on OLIS from when I heard the bill in November in my committee. Then we have a omnibus child abuse prevention bill to really reduce the, try to intersect earlier and reduce the childhood trauma and the ACEs scores that come out of child abuse. So that's both preventing kids from going into foster care, but it's also all the other kinds of trauma that they experience. There are medical directors that get reimbursed for their services in these, but they often do not get reimbursed highly enough. It's very dependent on which CCO and which private insurance. And so some areas of the state have better coverage, reimbursement coverage than others. But the state needs to put in, I mean, that is something that we need to focus on. How do we get insurers to cover these more evenly? But we've tried that in the past. That's been hard. And so this is really direct subsidy state to cover more of their costs. And then there's two bills that try to break the cycle at the age of kids who are aging out of foster care, somewhere around that would be, at age 18, doing a better job of trying to prepare those kids when they don't have any parents and they don't even have foster parents. What is the coaching that they get? So we do have a system in place that doesn't cover anywhere near enough kids because we haven't put enough money into it. And we also reimburse at only $200 a month for case management, and that's been the same rate for years. And as you can imagine, costs go up due to salaries, rent, light, everything else. And a lot of these groups are starting to say, we can't do it anymore. We're so subsidizing it with our unrestricted dollars, we can't do it. So putting more money into that, it's called the Independent Living Program throughout the state. And then lastly, unaccompanied homeless youth, same thing. Both foster kids and unaccompanied homeless youth have the highest rates of children that end up back in the foster care system, whether they're intentional or unintentional pregnancies. They are at highest risk for kids who end up either homeless or in the foster care system. So those are really my top, take home. 3 out of 4 of them were, the first 3 I mentioned were all ranked the highest on my Human Services and Housing Committee last year. We went through a bipartisan process. We put the results up on OLIS of what our highest priorities were, and they weren't funded, and that was a really big frustration for me. And so I've been very vocal about that ever since on the floor last June when we did our Christmas tree bill, and ever since I've been saying we have got to get on top of this, or we are going to continue having a CSL, continuing service level, that exceeds our needs. It keeps growing. And everyone keeps talking about a structural deficit. And my belief is that unless we go upstream and start funding some of these things, of course we're going to have a growing, continuing service level on all these child welfare and other kinds of programs. So those, I think, are the main things. I do have some housing-related bills I could talk about as well. But I think I'll just stop and ask any questions. And Dan, hopefully you have this at least in front of you on the computer so you can see page 2. Page 1 was my priorities. Page 2 are the other things I'm supporting. And if I'd love to see if anyone has any questions.
Yeah, thank you, Representative Kenny Guyer. Let's pause there for a minute. Everybody was listening attentively, and I think even as we wrestle with kind of just the basic functioning of the insurance market, making sure that coverage is accessible to people through the marketplace, the long-term vision for the marketplace was always that we would get the market stabilized and then be able to address some of the upstream determinants of health that you're outlining. And, that's the vision, and we appreciate you keeping that vision alive, even as we're wrestling with some of these more basic issues around subsidies for insurance and reinsurance, et cetera. So while we have you on the phone, and I know you're in transit and headed to another meeting, while we have you, I just want to give people a chance to ask questions about anything, but especially some of the topics she covered. Let me throw out a question, what you really hope to accomplish during the short session. Representative Salinas delineated between the long session and 21 and the short session. Are there some important things that we need to be aware of during the short session, or is your focus on sort of laying the foundation for the long session?
Yeah, my hope is that we put kind of a stake in the ground in some of these things. None of the bills that I have enough of a comprehensive plan or enough of a request for resources to address the issues as they should be addressed. For instance, in the unaccompanied homeless youth, we put in about $1 million a year right now into that, and it's among the lowest in the country, even though we have the highest rate. And the Casey Family Fund did a report back in 2007 that said we should be putting $6 million a year. We're only at $1 million. So what this bill does is it, number one, puts in $1 million into our existing network of 14 providers just to help stop them from hemorrhaging. It's nowhere near what we should be putting, but they have had a really hard time doing outreach, getting the mental health services for their kids. They've got beds, but they could do a much better job, and they could probably increase the number of beds if they had a little more money. So it's just a stake in the ground. It's not going to meet the need. Second part of the bill funds for the first time a host home program. Those are developing homes, not a shelter, but a home. And this is developed by Ecumenical Ministries of Oregon and other groups that do it. They've been doing it for years, but they could serve so many more kids if they got some state help. The third part of the bill is to do an assessment of what are the needs of unaccompanied youth, where are they, who are they, what kinds of settings would be the ideal ones for them, and then what's already out there and how can we fill in the gaps. So that, of course, sets us up for 2021. We hope that we can not just wait till 2021 because this is a huge crisis, and we devote about 25% of what Washington State does per kid on this. So it's a little bit of a stake in the ground in terms of enhancing the services that are already out there. But the really critical piece, of course, is also the assessment, so we can come in 2021 and do a much bigger, more comprehensive and a more fully funded system. So that's the hope. Same with the foster youth. They need a lot more than what we're asking. We're just asking for $2 million to both increase the rate from $200 to $300 a month for the case management of these kids, and also to reach out to 200 more kids. That's what this would fund. There's a lot more in terms of trying to provide housing, mental health, et cetera. So these are all kind of basically stakes in the ground. The Family Treatment Court is to roll this out in 5 counties. Frankly, I doubt we'll get all 5. I'll be happy if we get 2 or 3. But it's saying this is the direction that Oregon needs to go in. Let's at least start this. We do have one in Columbia County that works really well. They have them in San Francisco and various parts of the country. We need to go in this direction. So, yes, they are. I really hope they pass. None of them are fully funding anything. This is the direction that we need to start committing to. But I will say, given that you're the marketplace people, this is not on my list for short session, but I do want to just mention 2 bills. Well, a bill that I passed introduced in 2017 was House Bill 3091, and it was a complement to House Bill 3090, which said that hospitals need to have discharge policies, or if they don't have a formal admittance, then it would be a release policy when someone comes in with an acute care crisis, acute mental health crisis. And the complementary piece was 3091, which said, and insurance needs to cover it. And we had tried this in 2015 when we passed a similar bill, limited just to hospitals who have psychiatric beds and actually formally admit and formally discharge. That was, I think, 2023, I think, was the bill in 2015. And we tried at the time to get insurance to to pay for that, because you can't just ask hospitals to do a behavioral needs assessment, to follow up and do, arrange for follow-up care in the community within 7 days. All the things that we wanted hospitals to do should be paid for. But several insurance providers came to me. They said, we know you have the votes in the committee. We know you have the votes on the floor. But we are doing a lot in this direction anyway to figure out what we should be covering more of in mental health. And we hope that you'll stand down on this and work with us over the next 2 years. And if you don't, we'll kill it in the Senate, and we're pretty confident we can do that. So we did stand down. We didn't. I withdrew it from our committee, and I chose to work with them. And we had really a lot of good meetings between 2015 and 2017. One of the people that we pulled into it was Gail Woods from DCBS, who helped us really see, because some of what the insurance providers said was, if you make us do anything that is not required nationally, then the state is on the hook to pay for it. And I kept saying, well, I don't get it, because mental health, this is in 1986, I believe, before ACA said you need parity between mental health and physical health. And Gail Woods at DCBS said the problem is it's not defined what that is. And so she really helped us figure out, if the statutes say in the emergency room section, you need a medical needs assessment when someone comes in and breaks a leg, and insurance needs to pay for the medical needs assessment as well as anything that is needed before the person leaves that hospital, then you can do the exact parallel thing for mental health. And that is what we did in 3091. So we said the hospital needs to provide a behavioral health needs assessment. That was in 3090. And it needs to do certain things before a person leaves a hospital, like set up a visit with a healthcare provider and a caring contact and a whole variety of things. And what 3091 said was, and insurance needs to pay for it. And I will tell you that I have been hearing very uneven reports on the implementation of that. And I am interested in May. I've asked the Behavioral Health Committee in both the House and the Senate if they will hold a hearing on this. And I'm working with the hospital and OHA and the mental health advocates to get a better sense of, at the hospitals, how are they implementing it?
Alyssa, hang on. We just all of a sudden had a technical problem and we lost your voice. We can hear you barely, but let us see if we can get it back.
Hello?
Yeah, we lost you for a minute.
I'm sorry. My car turned off because I have an electric car.
Oh, you were switching from your car to your phone.
Everything went blank. Yeah, exactly. Yep. So hopefully you got the end of what I said. It's partly passing bills, but then the implementation is critical as well.
We just missed the very end, you're very soft right now, so if you can speak right into your phone. I have one last question before we let you go. I understand that you have some thoughts about the marketplace transition from the federally facilitated marketplace to an independent platform, and I just want to give you a chance to share those with the Marketplace Advisory Committee before you sign off. And you won't be there to vote on the proposal, but I think your opinion matters.
Yeah, so, I hate to say too much to all of you who know so much more about this than I do, but from what I understand, I'm very supportive of it. It sounds like a lot of states have gone in this direction. We both are paying a lot for the federal system, and we have a lot of strings attached and lack of flexibility. And it's certainly a no-brainer to take an in-depth look at it. And I know there's a lot of people who are gun-shy, given our experience several years ago. And I am one of the few legislators left that were a part of that a few years ago, voting, for Cover Oregon. So I understand that, but we can't let our past trauma get in the way of what's right going forward. So I'm really glad that you're looking deeply into this. And from what I understand so far, and I'm sorry that I haven't read the full report, but just from hearing a summary of it from several people, to me it seems like the right direction to go.
Appreciate that, and for what it's worth, Representative Salinas said essentially the same thing. So we appreciate the support and the acknowledgement. The staff here did a great job of analysis. We actually had some invited testimony some time ago from other states, and we're continuing to monitor the experience of other states. So We think it's an important function of the advisory committee to bring this issue forward. The legislature gets to decide, but it's our job to pose the question.
Yep, good. Thank you for all your work on this.
Yeah.
Really, really important.
Thank you, and we'll let you sign off.
Okay.
We really appreciate the flexibility in joining us.
Okay, thank you for yours. Okay, take care. Bye.
And we will get her email message. I wasn't seeing it, but Chicky and I will coordinate and make sure that does get distributed to the committee so we have a written sample of her priorities. So, Jesse, I hate to tell you, you're now officially between us and lunch, but I want to give you the chance to close with any other additional bills.
It'll only take a few hours. Yeah, I just wanted to give everyone a heads up about the other bills that we're tracking having to do with health insurance specifically, because there's certainly some crossover interest there. First of all, our bill, we just learned, is going to be HB 4110. I don't know if people want the numbers. With the other bills, we're going to have to give just the LC numbers, which are extra useless, but I'll give them anyway. So the dialysis concept that Representative Salinas mentioned earlier is LC 6. Does a number of things. The two key things it would do for health insurance regulation are, first of all, it would cap the reimbursement for dialysis services at the Medicare rate for all commercial plans, or the state-regulated commercial plans, and then it would also cap the patient out-of-pocket amount at 10% of that. So it's a pretty aggressive cap. And I know that they're working on an amendment because they weren't happy with the way that was drafted, so we'll see what actually comes out. LC...
And Jesse, and would the dialysis providers be required to accept that as payment in full?
I believe that's the intent, yes. Whether the language gets us there is a little less clear.
Good luck with that.
So LC7 is there's an interesting backstory on this that I won't get too deep into, but it would create a committee within DCBS to review proposed health insurance benefit mandates, specifically to take a look at the ACA provision that actually the Representative Kenny Geyer mentioned earlier, or referenced, where the state has to defray the cost of benefit mandates in excess of EHB. And we don't think that bill is going anywhere in its current form, but it might wind up getting used as a vehicle for something else. We believe that part of what was motivating this is concern about the estimates of the impacts of mandates that were coming out from PEB and OEB. So there may be something looking at that more specifically, but we'll have to see. LC 18 is Representative Mitch Greenlick's latest run at trying to refer a question to the ballot that would establish access to health care as a right under the Oregon Constitution. So who knows whether that will go anywhere, but that's been kind of an evergreen idea. LC 59 is a concept from the Oregon Medical Association to try to reform prior authorization, step therapy, and utilization management under commercial health plans. It would do a number of things. It would extend the time period that a prior authorization is good for. It would, I won't go through all of it.
That's also an evergreen idea.
It's also a bit of an evergreen idea. There was a similar idea during the long session. They've made some changes that are supposed to be a bit of a compromise. So we'll see if it moves anywhere.
Is it accurate that bill carves out OEB and PEB and CCOs?
The intent is to carve out OEB and PEB. I think there's some question about whether it actually does. It does not apply to CCOs, though. They did take out the CCO part.
I always get concerned when that happens, because if you don't get the fiscal done, then sometimes that doesn't get factored into the real cost of these things.
And that was part of the issue during the long session, is my understanding.
Well, that's part of great point, and that's part of what DFR can help with, is understanding the impact on the private, non-public insurance market.
So then LC 92 is a big healthcare omnibus bill that does a number of things. It extends the timeline for the Universal Access to Care Task Force. It also has some CCO issues around financial transparency and member transfers, and then there's a provision at the end around the auto repeal of old health insurance mandates that we're taking a look at. It's a pretty technical issue that probably you guys don't care very much about. LC 102, this is an interesting one, has to do with pre-exposure prophylaxis or PrEP treatment, which it basically is designed to prevent the transmission of the HIV virus. So those of you who are following these things really closely may be aware that the U.S. Preventative Services Task Force recently recommended that that medication be added to the list of services that are available without cost sharing, and that'll be going into effect relatively soon. But what this would do in addition to that is it would ban prior authorization for those therapies. And it would also, apparently, Oregon is going to add PrEP to the list of drugs that pharmacists themselves can prescribe, so you wouldn't have to go to a doctor. So what this bill would do is it would also require reimbursement if a pharmacist prescribes PrEP, even if the pharmacist is out of network. And interestingly, this would also apply to other drugs prescribed by pharmacists. So it will have perhaps a broader set of implications.
Any other bills, Jesse? Are you?
Yeah, we got like 3 or 4 more.
Okay.
I'll try to be quick.
Let's do it.
So LC 144 has to do with drug price transparency, making some technical changes to our program, and also extending the drug price transparency task force that we've been participating in. You all may or may not care about that. I know you don't care about PBMs, so I won't talk about that. Okay, 2 other concepts. One is actually a legislative concept connected to what Commissioner Stolfi was talking about earlier, capping insulin out-of-pocket costs. We believe there's going to be a bill on that introduced by Representative Scouten that would cap co-payments at $100. And then there's also a bill that would create a system for, or at least direct the state to apply to set up a system for drug importation from Canada. I think there's a lot of members' bipartisan support for that. So we'll see whether anything happens on that. There's a lot of other bills, but they're mostly having to do with the delivery of health care rather than health insurance. Anybody have any questions about any of those?
Jen joined us on the phone from Bend. It's probably snowing right now, is my guess. I'm glad she didn't try and drive over the mountain. So I want to acknowledge Jen is here, at the same time offering people a chance. And I assume, Andrew and Jesse and Tasha, that we can have you back later in the year, especially Jesse, as some of the concepts for 2021 get firmed up. I think it actually is going to be really important for us to understand, with a laser focus on those that affect the marketplace and the work we're trying to do here around affordability. So appreciate this, and we'll definitely keep this discussion going throughout 2020. Was that a question?
I do,
Look on your face.
I know I'm
Greg?
delaying lunch too, but
This is important.
So that sounds like a lot of bills, and I think Jackie's gone. But are we going to have a session, or is there any feeling about how that's going to?
Session will start.
Okay.
Yeah.
From there.
And then it has 35 days to end. So yes.
Great. All right, with that, I'm going to bring us to a close, and I was rushing a little bit because we do have someone lined up at 1. So let's take a quick break. I want to do 2 things before we break. One, I want to leave room for public comment. Do we have any member of the public who wants to talk? We will offer another opportunity for public comment at the very end of our meeting. And then for those of you who have been ignoring our speakers and reading the minutes, I want to make sure that you know we're going to review the minutes and approve them maybe when we reconvene, because we do have somebody leaving at 2, and I want to make sure we get that done before we adjourn. So nobody was ignoring you, I'm sure. That was a joke about reading the minutes. So let's take a quick break, grab our food, and we'll come back in a few minutes. Ask everybody to do is mute your microphone.
We're not crunching into it.
And I'll even mute mine once we open with our guest. And that way we can keep eating and not interrupt. So everybody mute your microphone and then just press it when you're ready to ask a question. So we're juggling the agenda, and what I'd like to do is give you a preview. We have some people that are leaving, and so we're going to move some things around. Want to apologize in advance to Katie and Anthony. We're going to ask them to stick around a little bit. We're going to get to you. We have time on the agenda. And I apologize that we're scooting you to the bottom. What we're going to do now is we have Stephanie Cannon on the line, and Stephanie will give us her usual update. I will make the usual joke about nothing going on in D.C. She will give us her update, and we'll go from there. We'll take that to about 1:20 or 1:25. And then at about 1:25, what we'll do is we'll approve the minutes. We're going to recognize some departing members of the committee. This is the last committee meeting for a couple of our committee members, and we want to recognize them and thank them for their service. And then at 1:30, we're going to go right into the discussion led by Victor, but including all of us, around state-based marketplace transition analysis. And that way we can have Stephanie stay to participate in that, since she led us last year in some of those discussions, and then Jeremy, who also has to leave. We'll take that till about 2 o'clock or so, maybe a bit longer depending on the discussion. And then we'll go back to our regular agenda, which has Anthony and Katie. And if you didn't follow any of that, that's fine. Chicky and I will manage the agenda. Just wanted to give you a sense of why we're moving things around, because we're going to lose some people after 2 o'clock. So let's jump in. Stephanie, are you on the line from the nation's capital?
Yes, I am.
All right. Appreciate you joining us.
I hear a little echo.
I don't hear it.
She's probably logged in on the computer and on the phone. That's what
Oh.
Nope, it's me.
Okay, I wonder if I turn mine off, if that helps. Go ahead and talk, Stephanie.
Okay.
Yeah, that was better.
Well, Happy New Year.
Happy New Year.
It is a little better, yes. Let me step back to December 22nd of 2019, when the government was funded for the full fiscal year. In that bill was a repeal of the medical device tax, a repeal of the health insurers tax, and a repeal of the Cadillac tax. The tax repeals were estimated to cost $375 billion with a B before interest over 10 years. The reason they did them in the funding bill is they could mush some money around to look like they paid for it. Also in that bill was a package of what are known as Medicare extenders, which you don't care about. But the reason you're going to care is because they're only funded through May 22nd, and then they go poof unless they are reauthorized. That gives Congress an opportunity for a health care package using the extenders as an excuse. And every lobbyist in town is trying to line up something to attach to whatever that extenders bill looks like. Let me now move to this year. Surprise billing is still an issue. That was the issue that was supposed to be an easy one that was going to be done by the middle of last year. At the very end of last year, there was a bipartisan, bicameral agreement on how to move forward on surprise billing. The controversy there is arbitration versus rate setting for out-of-pocket, out-of-network bills, and what kind of combination of arbitration and rate setting do you have? Nobody was really happy with the bipartisan, bicameral bill. So earlier this month, the House Ways and Means leadership, the chairman and the ranking member, got together and apparently drafted their own bill, and they're now trying to put it into legislative language. They have not talked to any of the other committees. In fact, I was in a meeting yesterday with both Energy and Commerce and Ways and Means Committee staffers, and when the Energy and Commerce staffer asked the Ways and Means staffer what they were working on in relation to surprise billing, he rolled his eyes and said, well, I understand the concepts. I'm not sure we're ever going to get the legislative language right. the House leadership would like to get surprise billing done before May, but if not, then they expect to have it on that May extenders bill. Drug pricing, another hangover from last year. The House passed what is known as the Pelosi bill. That's the bill that permits negotiations for drug prices. They sent it over to the Senate. It is in the Senate graveyard. Mr. Grassley, the chairman of the Finance Committee, has revamped the bill that he and Senator Wyden worked on together and got out of Finance. It has not received floor time because by Mr. McConnell's count, it doesn't have the votes to pass, and he's not going to put it on the floor until it does. The Senate Health, Education, Labor, and Pensions Committee still has a drug package sitting out there as well. It's largely FDA related and about getting more drugs to the market. That has not been taken up. It had a lot of support, but it was in a larger bill that had surprise billing in it, and they don't want to move anything related to drugs until they figure out what they're going to do with the finance package. Excuse me. Meanwhile, the House Energy and Commerce Committee reported out several small bills, largely FDA related, but then some of them were also similar to what Mr. Grassley and Mr. Wyden had in their bill. They sent them over to the Senate where they're sitting there also waiting. So because the Senate is, shall I say, otherwise engaged right now, we're kind of in a pause mode until the Senate is back up and doing other business other than impeachment trials. One note, last week a poll came out that said the public didn't think the administration had done enough on prescription drug prices. So the president, in his unique style, called up the Secretary of Health and Human Services and chewed him out. And that probably will prompt some more action from the administration, perhaps maybe jump-starting a long-delayed plan tying drug payments, certain drug payments, to prices paid for the same treatments in other developed countries. On the Hill, the Republicans hate this proposal. Trump really likes it. We'll have to see what happens. Azar was out yesterday and today talking about how wonderful the Senate Finance Committee bill was. So wait and see, more to come. Also, last December, the administration announced a plan to permit Americans to import drugs from Canada. Several states are looking at how to facilitate that. So you might expect more on that. Now I'm going to talk about a rule that the administration put out concerning abortion and payments. The rule was first proposed in November of 2018, and the final rule came out in December. It requires health insurers to send plan members. Let me back up. It entirely separates the monthly bills for abortion services in premiums from the other services covered by that plan. It's effective June 27, 2020. Insurers are concerned this is going to confuse people. CMS has acknowledged that it is a new process and it will confuse plan members, and people could lose their insurance if they don't pay the separate bill for abortion coverage. But the agency is also says that it thinks it's worth the risk. And they're not going to take enforcement actions against an insurer that doesn't terminate a plan member's policy for non-payment for a little while. CMS estimates that complying with the rule would cost an insurer a one-time expense of $2.7 million in 2020. Collectively, across all insurers, it's estimated to be $385 million for nearly 3 million hours of work to do this. That does not include the ongoing annual costs, and insurers are very concerned about the ongoing costs, in addition to the one-time costs. The 3 state-based exchanges that perform their own billing and payment processing are also going to incur costs for doing that every year. CMS estimates that there are about 3 million individuals who are enrolled in exchange plans that covered non-HIDE abortion services in 2019, HIDE being the HIDE Amendment. The rule also has a section large section that steps up CMS oversight on state-based exchanges to make sure states are correctly identifying people eligible for premium tax credits and cost-sharing reduction subsidies. It also clarifies the scope of audits that the state-based exchanges are already required to conduct each year. And it adds a new requirement that state exchanges must test enrollment and eligibility transactions. It also states that beginning in 2021, federal and state exchanges must perform periodic data matching at least twice a year to ensure they're identifying individuals who have become eligible for other coverage that bars them from receiving federal subsidies. I'll just note that CMS is on a very big oversight of how money is going to a number of programs, including Medicaid. So this is not out of character for what they want to do in Medicaid. So everybody's being treated pretty much the same. They're just going to really watch the money very carefully. What else? That leads me to the courts. There probably is going to be more action on healthcare in the courts this year than in Congress. Let me take the Texas VA case first. The lower court ruled that it was completely unconstitutional. The whole law was unconstitutional. The appeals court said, well, the individual mandate is now unconstitutional, but we're going to send it back to the lower courts to review what could be saved that may not be that closely related to the individual mandate. And their actual language was that the lower court should go through this with a fine-tooth comb. The Democratic AGs who've been leading on this case decided that they wanted to not wait for the lower court, but to try to get the Supreme Court to take it up now. And this week, the Supreme Court ruled that they would not take it up. So it's back to the lower court for him to go through with his fine-tooth comb to figure out what may or may not be severable from the individual mandate and thus would stay as law. So more to come on that. There are a number of other cases I just want to remind you from the ACA. There are the risk corridors, the cost-sharing reduction payments, association health plans and short-term plans, the contraceptive mandate, the ACA's non-discrimination provisions, and then there's the case that's known as the Take Care case, which alleges that the president is not doing his due diligence to actually enforce the law. So all of those rules are going to have something going on this year. In fact, the Supreme Court just agreed to take up the contraceptive mandate case, so we'll have a ruling next spring. There's a couple of things that are out there that are Medicare related that I just want to highlight because they will, depending on what happens, they may impact the market and prices. Medicare put in a policy called site neutral. It means that if you get a outpatient surgery, for example, if you have it in the hospital, in an ambulatory surgical center, or in a doctor's office, it would be paid the same. Medicare went ahead and implemented this, but there is a court suit out there about it, alleging that this is not really authorized under Medicare. The other case is probably larger, and that's the transparency case. Medicare put out a rule requiring all hospitals to make their prices known, including their negotiated agreements with insurers. The hospitals have sued, saying this is a violation of a hospital's free speech. So that also is something that could impact others. There are a number of cases related to Medicaid that I won't go into. And there are going to be more cases related to Medicaid as soon as CMS does a few things, like approve a state with a waiver for a block grant in their Medicaid program. A couple of other things I just want to cover. The public charge rule had some action recently. Let me just give a quick history. In October, a New York judge issued a nationwide injunction blocking the rule, but a federal appeals court ruled in favor of the Trump administration last month, granting a stay on the rulings that have blocked the measure from taking effect. It was a 2-to-1 decision. Then the decision by the Ninth Circuit Court of Appeals didn't have the immediate practical effect because the policy was still on hold because of other rulings. A lot of rulings going on. So this week, the administration asked for an emergency ruling to lift the injunctions. No one has ruled yet, but this administration has used going to the Supreme Court asking for an emergency ruling more than the three administrations before it combined. So we're waiting for that rule. And I'll just mention the conscience rule that was issued in May by the HHS Office of Civil Rights. It expands the ability of medical professionals to refuse to provide care based on religious or moral objections. There are multiple lawsuits over that particular rule as well. I think I'll stop there. That was a lot. Any questions?
Yeah, sorry, Stephanie, I was getting off mute and looking around the table to see if there's any questions. We have one somewhere. We actually have Jesse O'Brien, who was, you may remember, formerly on our committee. He now works for the state Department of Financial Regulation. And there's no other questions from committee members. Jesse, go ahead.
Thanks for the indulgence of the chair. I'm not actually a committee member, but Stephanie, correct me if I'm wrong, but my understanding with the Texas case is that the Supreme Court didn't deny cert on the case, they just denied expedited consideration, so they may still take the case up in their next term, starting in the fall, but we wouldn't actually get a ruling until next year, probably, whereas if they had expedited it, we might hear a ruling this spring. Is that right?
You are technically correct, yes. Some of the folks that I have talked to have said that they don't think the court will take it up until the lower court finishes going through what they think is severable or not, because they would want somebody to do that work first. They could then take it up then. But most people think they want the poor judge in Texas who said, "Oh, you're just going to appeal me anyway," and got it out of there, has to do his homework.
Yeah, I've heard speculation going in both directions on this, and this is all pretty inside baseball, but granting cert on a case only requires 4 justices, whereas granting expedited consideration requires 5. So that that would mean that it would be more likely that they would take it up because they'd only have to have 4, but who knows what their internal deliberations are like.
And the Chief Justice is a little busy for the next couple of weeks at least.
Any other questions for Stephanie? What did she say?
Oh, usually there's somebody.
Katie, go ahead.
Hi, Stephanie. This is Katie Button. I do plan management for the marketplace. Have we heard anything about the payment notice? I know your last email was like it's been sitting at OMB forever, but I have to ask.
In fact, I just checked the OMB website to make sure that I was still accurate. They still have it listed as a proposed rule, and it's been there since September.
Maybe there'll be a Valentine's Day present to us.
Well, I will tell you that the insurance industry has gone ballistic, and they are trying to lodge it out of there. The odd thing is that there's been absolutely no information about why it's taking them so long.
Thank you.
Sorry, I don't have better news.
That's all right. I have to ask.
It's okay.
Stephanie, appreciate your flexibility on time. Any final questions before we let her go?
Do you mind if
Yeah, Craig Anderson.
Yeah. Stephanie, thank you. You covered a lot here, but there's actually one that's kind of on my mind. It's the 21st Century Cures Act and interoperability, and it seems like it's kind of on my mind because I just saw a presentation about this yesterday, and it seems like a big deal to allow consumers access to their medical information from carriers and providers and the timeline of that. I'm just curious if is that getting any buzz from where you are?
You know, that act had a lot of stuff in it, a lot of things that take a while to get regs and rules out. And I know they're working on things, but I don't think anything's popped out yet, even as a proposed rule to implement. I will tell you that there are a couple of congressmen who are also the same cast of characters who led the last Cures bill are now working on a Cures 2.0. And whether that sees the light of day this year or not, I don't know. But they want to. Part of what they're working on is some improvements from what was in the other bill, and then they're working on trying to figure out a pathway for drugs and devices to be approved by FDA and get into CMS faster. So several people think that maybe the threat of another bill will pop out more of the information needed about getting your private information from your insurer.
Thanks, Craig. All right. If we don't have any other questions, we'll let Stephanie go and we'll move on. Appreciate it. And I was listening to the radio on the drive down, listening to live impeachment testimony. So my guess is that is still going on right now, even though it's late in the afternoon.
It is still going on. Adam Schiff is actually talking right now.
All right. Thank you again, Stephanie.
Take care. Bye-bye.
Okay. Speaking of Stephanie's, I want to do two things. First, we'll approve minutes, although we may have lost our quorum.
You have Jen on the phone still?
Jen, if you're on the phone.
I'm on the phone. Yes, this is Jen.
Okay, I'm going to ask somebody to make a motion to approve minutes.
Move approval.
It's been moved. Any seconds?
I'll second.
All in favor of approving the minutes from our last meeting, please say aye.
Aye.
Opposed?
Aye.
Minutes are approved. Okay, I think everybody knows we have two departing members of the committee. Joe's still in process, but the two that we know are leaving are Stephanie and Cindy Condon. Cindy's not able to be with us today. Stephanie is, and I know she has to leave in a minute. So we want to just thank you for your service and appreciate everything you brought. And you were here at a critical time where we talked about the transition, and that's why I want to have you here as one of your last conversations with us to talk about that, because I thought the work that you and Shannon and others led was really very impactful, as you can see from the state legislators' presentations. So maybe a quick round of applause, and we have a certificate of appreciation. And it's not too late to change your mind.
You know, I was thinking about looking until like one day. It's so exciting. My message, she very bittersweet. When I first started my job at Oregon Primary Association, all about
thank you. Medicaid enrollment and the C word, Cover Oregon, and really helping our FQHCs, or Fairly Qualified Health Centers on the ground, message about insurance and this new opportunity where they might be eligible for Medicaid, or that if they make a little bit too much for Medicaid, there were these options. And so it's been really nice to kind of see this transition forward, and it's bittersweet to kind of leave during some of this exciting time. And again, I feel like I'm just learning some actuarial stuff. When Craig and Ken talk, I'm like, I don't know what's going on, but then I Google it and then I learn. But
that's no matter what they're talking about.
There's like words that I circle and I Google, but I feel like
you are still more than welcome to change your
Okay. Well, I will let my role has changed in the organization, and so I have let my colleagues know that there is an opportunity if they wanted to join and see, because I think this is really connected again to our mission and values and how we support our health centers and throughout Oregon. So maybe you'll hear from me, and we'll see when the time is right, and maybe I'll be a public comment person on the phone as well. But thank you. It's been really great, and I've learned a lot.
Thank you, Stephanie, and thanks for your service. You brought an important perspective, and I get confused when those guys talk as well, and I'm in the industry, so it's not personal to the topic. So Cindy is not here. We'll get her certificate to her and thank her as well.
Yes, so Cindy was one of our founding members of the advisory committee and has brought a fabulous insight, her knowledge, her passion for the marketplace, and rather just healthcare in general, making sure that we can get as many folks covered at a price point, rather, and at an affordable rate. It is very, very important to her. She has been very involved throughout the years. We will miss her. She is our only representative in terms of the consumer stakeholder group. It is a very hard population to get members to join our committee, so she will be truly.
Jim's a consumer now.
He is. He's still with Small Business Alliance. So,
Oh,
but
all
yes,
right.
he is also a consumer. Cindy is an actual consumer of the marketplace in terms of getting signing up through healthcare.gov. She has been very a key player in getting feedback in terms of how the exchange works through the healthcare.gov, how we can improve our relationship. She has given us so many ideas. A lot of our projects and our products were a result of conversations that Cindy had brought forward to us. So truly love and appreciate all her time. So thank you, Cindy. I don't know if you're listening. I think you said you weren't even going to listen, but at least it's in public record. We will miss you. Look forward to seeing you around town.
I also had a nice little email exchange with her, and she, expressed her thanks to the committee for everything. And I think I noticed on the nominations list that she was nominated to some other state committee.
Oh, good.
I thought first that they had her misassigned, but
No, I do throw out her name every so often when folks from the governor's office ask me, "Hey, do you have any recommendations for this or that?" And your collective names come up every so often. I do nominate you for a variety of different committees, so that's really good to know.
I saw that as well. I don't remember the name, but I do remember thinking, Ken, that whatever she was nominated for was not nearly as exciting as the marketplace.
Well, obviously.
Nothing is, right?
Nothing is, yeah. Okay, so thank you. And I think, again, we're going to switch right in now to the transition issue. Victor, if you're ready for that, we'll do that till about 2 o'clock. And then I think Jeremy and Stephanie both have to step out shortly thereafter, and we'll go into the last part of our agenda.
Thanks, Dan. Well, we'll jump right in. As you can tell, even speaking today with Representative Salinas, who's very supportive of our work, we can expect, at least for a little while, to keep hearing phrases like when the time is right or not quite yet. So we don't know exactly when we'll be engaging fully in this with a lot of stakeholders, but in the meantime, there is still plenty of work to do. And we are kicking off with this not working. Cool. With other states that are currently undergoing the transition to a full state-based marketplace, Nevada, of course, was one we've been following for a while because they were the first ones to give it a shot. This OE, open enrollment for 2020, was their first one as a full SBM, having transitioned with the company Get Insured, doing their call center and their technology. It was a success. They had quite a bit of work to do leading up to it. But by all means, they didn't have any unplanned downtime, and looks like everybody was able to enroll as normal. The one thing I did notice, just tracking on my own, is that I had a Google alert for Nevada Health Link and a few other things just to see what came up. And there was a lot of local media, but what would come up was usually either advertising for Nevada Health Link, or it was Nevada Health Link's personnel actually speaking to the media, giving interviews. Overall, just seemed very neutral at worst, or supportive of what was happening in Nevada. So that was good to see. Don't know if we could expect the same, but Nevada did have some similar circumstances early on with a failed exchange. So some hope, at least, for optimism there. Next is New Mexico. They followed not too long after Nevada, but they ended up having some much longer timelines. They don't have as much public information available on their websites that I could find, and I try to, as much as I can, to pull information from places I know I can readily just share with anybody who asks without much of an issue because it's already public. So they selected their vendor last year. They're still an SBM FP for this year, And it looks like, and I've seen a couple of conflicting dates. It's unclear if they're planning on also being that next year and then being ready for OE 2022, or if they're actually doing OE 2021 this year. So we'll have to kind of nail that down. But at any rate, moving at a slower pace and with some kind of different parameters than Nevada had. Next is Pennsylvania. Pennsylvania and New Jersey last year announced their plans to transition to a fully state-based marketplace with a little one-year stint as an SBMFP in between, and they are moving really fast. We saw early on when they had planned to do an open enrollment for 2021 this year, we thought that's kind of impossible. That's way too fast. You can't get a vendor. You can't implement that fast. And we were wrong. So they had done an RFP last year. They selected their vendor and announced that in 2019. And there was enough information for me to actually collect some public contract information, which I'll be sharing with you in a bit for comparison. So on the upside, that is another sort of example we can add to kind of hone our own estimates for what something like this might cost. It's a nice bookend. Nevada is a smaller state than us. They have lower enrollment numbers, and therefore sort of basing cost estimates on just one instance is a little more difficult. Pennsylvania is much bigger than us, and so they have an enrollment closer to about 350,000. So it's a great sort of other end of the spectrum for us to kind of start narrowing in on our own estimates. New Jersey, fairly similar, and right at about the same time as Pennsylvania. Again, ultra quick timelines compared to what we've seen and you know the bit that we know about how this works, but also managed to at least pull off their RFP, select a vendor, and do have plans for anticipated launch this fall for OE 2021. So we'll be tracking those very closely to see what their progress is, see how they go. They structured theirs a little bit differently, so this was a good, they had ended up selecting different vendors for their technology and consumer assistance centers. So that's something we haven't seen yet, and it looked like they wanted to do those for different amounts of time. So their technology contract was for 5 years. Their consumer assistance center contract was for 3. And it may be that they're planning on standing up their own at some point and kind of phasing out the contracted assistance center, but we'll see as that goes on. One thing I did forget to mention about Pennsylvania, another great example they provided is that their RFP required that the vendor submit only one submission for both the technology and the call center. So we had thought about what if we required bundling or what if we required them to come in as a package. Pennsylvania did that. We don't necessarily know what that does to the vendor field. We guess that it would narrow it. Not as many vendors would be able to do kind of propose for both at the same time, and what that does to costs. But hopefully there'll be a few more bases for comparison as we go on. Virginia announced a little bit later than the rest. They don't have any firm plans for a full SBM switch, but they do have some bills that have been introduced in their legislative session this year to carve out that roadmap and have a firm path to do that. So all of their timelines and RFPs and all that will depend on the outcomes of their session. We'll be watching that pretty closely. And then lastly, Maine jumped in and said that they'll be transitioning to an SBMFP this year for OE 2021, so that'll be fall of this year. And they also have introduced some legislation to make that happen. But they don't have any sort of even roadmap plans or anything to transition to a full SBM yet. So right now it's just kind of getting their feet wet in the state-based marketplace and that management and what that entails. And then we'll see where they go from there. So Chicky asked me to put together some open enrollment comparisons. Oh, sure. Yeah.
This is really helpful. I want to just pause for a minute and give people a chance to comment. One thing that strikes me, Victor, is I see that some states are moving in terms of state time pretty quickly. And I'm wondering if you have any sense of what's behind that. Is it political? Is it financial? Is it logistical? What is that?
Just from an outsider and not expert in a lot of other things, but what I'm doing perspective, just from my own reading, it does appear to be largely politically driven on that side. Those states did have recently a big switch in the majorities in their legislatures and newly elected governor, and there have been a lot of reforms that have been made that have followed suit. So the push to have a full, their own exchange was part of that, I think. And I don't know from a just everyday normal state exchange doing an IT project perspective, what their process looks like, and if they're going faster than that, or if things just move faster in those states. But in either case, it is no less of a complicated and large body of work. Both of those states are, New Jersey and Pennsylvania, are bigger, and they do potentially have a larger pool of money to draw from. So it's more than likely that they just had the funds to hire enough contractors to get all of the details together quickly.
So other questions, I know we're going to go to a full discussion, but other questions just about the transition timing of those states, the information he just presented? And by the way, the big gun rally in Virginia, was that related to the transition of the...
Hard to say.
Separate?
It didn't seem to come up.
Okay,
so, yeah, no.
Just want to know what we're getting into. Questions about the data he just presented before we go to open
Mine's
enrollment?
sort of a follow-up to yours, which is, are they showing it, is part of what driving it that they're saving money?
Yes. Yeah, absolutely. So they're at 3% of premiums like we are, or 2.5%. Rather, they're coming from full SBMs not that long ago, or full FFE states rather, not that long ago. So they're fully dependent on the federal technology, and they've only started making these switches. So they were paying 3.5%, or their carriers were paying 3.5%. So they're basing a lot of their savings even just coming shortly off of that, and that makes them even bigger. But again, for bigger states where you have that bigger pool of money to pull from to begin with, the savings can be even greater. So yeah, we're talking definitely tens of millions.
Ken, go
very,
ahead.
very quick observation. It's just, it's interesting. We all, and not just this committee, we spend a lot of time talking about all the uncertainty around the ACA. And yet within that environment of uncertainty, we have all these states going to state-based systems, and many states moving now that held back on Medicaid expansion. So it's kind of curious that within that uncertainty, we're still seeing movement ahead.
So Ken, I think to piggyback on that, I think the last couple of years, one of the changes that we've seen from CMS is their emphasis on state flexibility.
Mhm.
They've started, that's why they started introducing 1332 waivers. They've really touted reinsurance programs. So I think I hope it's not just a trend, because they have recognized that states are better served if there is local control or if there's local access for their citizens. So I think that's been a very strong and common theme that we've been hearing from the states is this is what the federal government has been saying. They would like to give more flexibility for states, so they are using that to expand, or rather expand their reach in terms of providing more options for their citizens.
Yeah. And just probably one more piece that adds to that is that it's hard to really kind of quantify how much the change in technology landscape has changed the game for a lot of those states, but they no longer have to consider iterative software development to create something that doesn't already exist, to do something very, very complicated, to pull from many different sources. It's all done. So when you don't have that uncertainty of how long it's going to take to make something, and you just know that all you have to do is do really good contracting and really solid research and detailed project planning, those things are actually easier to do if you do them right. Iterative software development is an unknown before you start doing it, so you don't really know how long it's going to take, but you can guess. So just that unknown taken out of the equation makes all of these things move much faster for these states.
I'll just wait till the discussion.
Okay, so let's get you through your slides as quickly as possible so we can go to the discussion, because I know there's some good questions.
One important thing to note, and we kind of put this in as a bit of a reality check. These are comparisons from Open Enrollment 2019 and then Open Enrollment 2020. I put Nevada at the top just because they are the ones that actually transitioned, and their 2020 numbers of 77,410 enrollees for OE 2020 enrollment are on their new platform as a state-based exchange. As you can see, they had a drop from last year's enrollment. What that's attributable to, hard to say, because this is essentially their baseline year as a full SBE. So they're just getting their own data now. So I'm sure they'll be looking at that and probably discussing that among themselves. For comparison, I added the other states that I mentioned on the other slides. And you can see some big drops, but the biggest drops, I put the footnote there, those were states that also did Medicaid expansions. So there was a good chunk of those folks we presume went to Medicaid, so that's contributed to part of that enrollment drop. But having an exchange active in your first year isn't some kind of magic bullet that makes your enrollment higher. That's kind of what the point of this is. So we shouldn't necessarily expect that it will suddenly make everything much, much better. It is a tool that can then be used to hone and create better experiences in later years, we're guessing. One thing that remains to be seen is how Nevada's effectuated enrollment numbers differ from their initial enrollment numbers. We don't know if that'll be different off the federal platform or not, but that'll be interesting. So we'll be looking at that as well. Are different, yes. Sorry, I meant to mention that. The table I had created, for some reason, one of the columns got scrambled, so the numbers, that's right. So we'll be sending out an updated version of the slides. The slides you have are incorrect. So that's for that slide. Any questions about that? Okay. And then next was just, now that I had some information about the contracts from Pennsylvania and New Jersey, in addition to the ones from Nevada, did some comparisons, very simple. It's busy because I had a lot of caveats there. Mostly I just wanted to explain where all this information came from and that it's all relatively comparable. So it was just how I did it in case anybody had any questions about that. So Nevada's year one maintenance and operations, this is just their first year, what they're paying just to be on the platform. This is after implementation and development. So $5.2 million comes out to about $578 per member per month based on their own enrollment numbers. New Jersey, Pennsylvania. New Jersey's I based on their RFP because we didn't have contract details. And so theirs comes in at between $4 and $480 per member per month. Pennsylvania, about $586 a month if their projections hold up. So not about what it's good that the trend seems to be consistent. The states aren't paying too much more or too much less as these contracts come about. Oregon, on the other hand, next year as an FP, or this year, we'll be paying somewhere in the neighborhood of $20 million if projections hold up. These are based on the assessment numbers from the 2020 assessment, so this is from last February. But per member per month, we're guessing about $14.70. So there's a bit of a difference in what just a per Oregon resident impact to premium, that sort of thing. In big terms, in overall premium numbers, a savings of $10 can make a difference to some folks, but on a larger scale, it ends up being, about $10 million, $12 million or so. So we can, we'll be doing some more studies based on that, but this is starting to be the basis of our cost analysis and what we'll be pitching.
As we do our work.
I will say once I put this down in this way, I was like, that's really what I wanted from the beginning. It's just the two extra states in their examples kind of fill this out. But and as more states do it, if they leapfrog us as well, we'll be able to add to this. But I don't expect that it would look much different.
So those numbers are that includes the technology and the call center.
Yeah.
So maybe to put that in perspective, I think that looks like that's maybe 1% versus what we're paying at 3%. So it could say, and we're talking about the reinsurance program saves 6% off premium. We might be able to carve a couple more percentage points off. So maybe that doesn't matter to the state because it gets passed to the consumers, but it matters to the consumers.
Yeah, Victor, do you or Chicky, you want to speak specifically to that 1470 because this is one of the key issues. It's good for us to understand.
I just will preface that by saying these were calculations that I had to make because those states don't assess per member per month like we do. As a matter of fact, I don't know that there are really any other examples of per member per month assessments. From a operations perspective, it seems to make more sense because it's a flat rate based on how many people we're serving versus a percent of premium, which is how a lot of these other SBMs are funded. So because of that, their payments, what they pay for their contracts, they're a flat rate. They're predetermined at the beginning of the contract, but they're based on projections that are a percent of premium. So I don't know that we would do our RFP the same way, if only because assessing by percent of premium is essentially more of ability to pay than it is how many people we're serving. So it doesn't necessarily get at the amount of work needed to hold people in an IT system or serve them over the phone. It seems like how many people would be a more important decider in that equation. So we don't know how we'll do it yet, but I just wanted to preface it by giving that context.
Okay, next slide.
What we're doing right now in terms of our own work heading towards an RFP, we're working on the business case. That's going to take a while. It's never quite going to be complete. It'll go through iterative processes, and so we're focusing on high level right now. Just your explanation, justification, different options, estimated cost, and so far, putting everything in a nutshell has been the biggest challenge. So we have lots of detail. How we make that detail intelligible will actually help determine how quickly this can go. The budget estimates we have to make we're modeling how much Platform and Consumer Assistance Center will cost based on other state contracts and implementations. Our own requests will have to balance how many people we ask for. We know we can get to an ideal number. We know that you don't always get the number of FTE that you want, so we also have to establish what's the minimum number of people we could actually do this with, extra people that we would have to ask for. And then projections for multiple annual assessments years in advance. Predicting an annual assessment is already kind of tough because you're doing it a year ahead of time. We're having to kind of do that 2 and 3 years ahead of time to kind of fill those projections out for our business case. And estimates. And the homework that Lou mentioned, we're working on that as well. We're observing very closely other state experiences. We're conducting ongoing dialogues and just looking at what media coverage for them is like. We're looking at some external resource availability. We've had some grants in the past from RWJF and seeing if there are other grant or information exchange opportunities with other states. And then I'm taking the RFPs from the other states because we know they worked because they selected a vendor. So we're taking those RFPs and we are deconstructing their requirements to see if we can get to kind of a place where we have a list of requirements kind of ready to go to present to stakeholders instead of trying to ask them for requirements. If we already know what is available and what can be done, it makes more sense to say, this is what can be done. Is there anything not on this list, or things that you like, things that you don't like? And it kind of puts us way ahead of the game in terms of collecting requirements, which can be one of the most time-consuming parts of putting a project together. And so, sorry, going really fast. Any questions about any of that first? Okay. So there are some dovetails with some ongoing marketplace work. We are conducting some business process mapping for our major program areas right now. The hope there is that we basically want to kind of dial in and write down everything we do, how we do it, and put it in a format that's easily understood by people that just understand business structures generally in a more universal format. It'll also really help us just for constructing that organizational transition part of our business case, saying these are the areas that will be affected, these are the processes, here's what we think will change, and just doing those gap analyses, and then and distilling those maps that we create out of those for our business case to create higher level maps, the things that show our relationships with other entities and how those things might change. And of course, just good business process. Just doing the exercise often lets you find inefficiencies and just trim the fat. So it's just kind of a good, healthy thing to do all around. We're working, of course, on the annual assessment. That will also kind of add to our budget projections. That work generates our own updated projections for enrollment, for pretty much everything that our business depends on. So one thing to keep in mind as you will look at the assessment for 2021 is that we cannot build costs for this into that assessment yet because we haven't got any approval to do any of the work. And that approval, I mean, is from legislature and OSCIO. That's not something we anticipated we would have had at this point anyway, regardless of when the conversation started. It's just something to keep in mind. So we cannot plan to have that money before we know we're allowed to do what we need that money for. And then for future assessments, any estimates that we make going forward after we do get some kind of preliminary project approval or LFO approval would be to anticipate project costs and account for the offset schedules of plan years and fiscal years. That can be kind of a tricky thing, not so much a tricky thing for people that do finance for a living, but plan years or calendar years, fiscal years start in June, and what money you collect for what work is a little offset and has to be accounted for in that planning. And then we are planning already now for the 2021 session. State agencies have to do really early planning, so we have to get our legislative concepts in. That also means budget projections, all sorts of things well in advance of even the legislative concept stage. And so we're doing all of that work at the moment. This project itself and any associated budget monies or anything else will need legislative approval. And so we're making sure we are ticking all the boxes to be prepared for when we're asked to give that information. Yeah.
Quick question. It hadn't occurred to me till just now on this slide that you've got there's a cash flow issue moving from the current system to the new system because you've got to start to build it and pay for it before you've actually launched it. So in those other states, did they do a general fund appropriation to bridge that, or did they?
None of the states we've seen so far have done a general fund appropriation. There have been a few different mechanisms that were used. Nevada had to do its planning because it was going to be insolvent because of the rise in federal fees, so they used some of their reserves to do their DD&I for that first year. In Pennsylvania, they actually deferred the DD&I billing to the first plan year, so they were able to, they deferred it to the length of the contract, so they amortized the whole thing over the length of the contract, 7-year contract. It's sort of a no money down buying a car version of that, so they took what would have been the down payment to build the thing and then built it into the subsequent years' maintenance and operations. That all depends on what the vendors are willing to do whenever they propose. I think Pennsylvania actually specified that in their RFP and still got the responses they got. So they said, here's how we want to do it. We don't have any money right now. We are not going to give you any money, but we'll start giving you money when we start collecting it. And the vendors were okay with that. So that is also a possibility. I don't, and then I think New Jersey, one of them also had a first year's an FP, like a small fee that they collected to try and put some money together ahead of time. So there's a lot of different ways to do it, but whatever it is, we didn't plan on anyway in asking for general fund or anticipating that we could. Kind of seemed to be a non-starter for a
So
lot
I
of
think,
reasons.
Victor, appreciate that. It's a very nice summary. You raced through it, but a lot of good information. And Jeremy, I don't know if you or Lou want to kick us off with some comments.
Well, there will be a discussion in February about where the marketplace ultimate home will be. Pat Allen and I are going to be talking to legislators about that. I would say that this discussion needs to wait until that discussion happens. The discussion about the state-based platform needs to wait until the discussion of where ultimately the marketplace is going to be happens.
Lou, what's the debate there?
Well, it's a question of whether the marketplace stays at DCPS or moves over to OHA.
So Lou, say more about that and specifically how the agency where it's housed would change some of what we just went through in terms of the structure of the marketplace platform.
It doesn't necessarily change what the structure of the platform is. It changes the timing. And, at what point does whichever agency is the ultimate home of the marketplace moves ahead? Because these requests are the agency's requests. They're not the marketplace requests. Mm-hmm. Whether it's, going to what used to be called the state CIO's office is now, I think, called the Enterprise Information Services Office. The agency goes to that office. The marketplace doesn't go to that office. So the agency is really the entity that moves this project forward.
I just add a couple of things, Dan, if I can. Part of some of the discussions between Pat and Lou have been sort of where's the marketplace best sort of fit in the overall structure of trying to expand access and lower costs. And so thinking about, things have stabilized. OHA has a much larger infrastructure for handling IT projects than DCPS does. I think that's fair.
Oh, yeah.
there's some things that we can't navigate regardless of where the agency is, and so that's what Lou's hitting on. And I don't know how this compares to some of the other states, but we have much more rigid IT processes now as a result of Cover Oregon, and that's statewide. That doesn't apply regardless of what agency you're in. But anything that's more than I think $1 million now has to basically have oversight of DAS. And I'll tell you, my team's going through a relatively minor, I think in the grand scheme of things, IT project, and that's been a 2+ year process. So there is only sort of so much speed on the IT side that we can really move at. I think you guys have done an incredible job of laying out the case. I mean, the numbers sort of speak for themselves. So the question is, where are we best positioned to really have that conversation of when and how do you move, and trying to put that in the context of what agency could best sort of move that forward, recognizing there's state stuff we're going to have to deal with either way. But there are some benefits of OHA. I mean, aside from being kind of more umbrella healthcare agency, and I'm not saying these will have an impact, but they're things we're thinking about. OHA is the only agency that can leverage federal Medicaid funds, so for some reason there's some offsets there. I'm not saying there will be, but we can at least think about that. We're going to be going through some procurements for some other enrollment system updates with our PEB and OEB. So we haven't gotten down the path of whether that would offset any of the costs, but there's at least we could be thinking about it in terms of some of the other broader kind of enrollment system updates that we're looking at over in OHA as well. And the conversation's just been, is there even an appetite for that? If the answer is no, that sort of changes the trajectory of what the next phase of this looks like.
It would be, to pick up on Dan's point, it would be nice if somehow that could get on parallel tracks and not wait for this long it's costing consumers $100 a year.
Yeah.
So, to that note, there's a lot of work that the marketplace can do to prepare for this, regardless of where its home is, whether it's going to be staying at DCBS or moving on to OHA. The rigor that agencies need to go through now to set this up is really pretty substantial.
No, I understand.
Yeah, and in fact, we don't think it's a good idea to even talk to many legislators until we've talked to, I keep referring to OSCIO, but they're now called the Enterprise Information Services Office, to engage them because they are the gatekeepers. It's all actually called the stage gate process. They're the gatekeepers in terms of moving forward with a proposal. So the homework can be within DCBS, making sure that we make the case to that office first, so that when we go to the Legislative Fiscal Office, when we go to key committees and leadership, we can already say, we have their blessing to move forward on this. So all of that homework can be done now and to kind of get ready for that. And that with the marketplace here, that involves our fiscal people and our IT people, because even if you get the go ahead to spend the money, there's still some internal resources that are in play. So all of that work can be done while this other discussion is going on.
Good.
And generally, so the other states have not. And again, I don't know how deep you got into the research there. I mean, other states have not been had to get a general fund appropriation. I'm not sure that's going to fly here, and the reason is IT projects largely are not even getting through that process without a commitment of a dedicated funding to see the project all the way through. That's one of the post-Cover Oregon new processes we have is they stagger funding now. You get a planning appropriation, and you don't get the approval from the CIO's office to actually go forward until you can show that all the dollars are going to be there all the way through the project. And so I think it is a multiple step process, both with CIO and the legislature, but that doesn't mean it can't be a parallel process or planning happening behind the scenes.
Jim?
So I'm actually glad to hear this because to Victor's report, I'm really glad that you reviewed and reported on the media, your observations on the media response, because I've gotten now 4 phone calls from a local reporter who was involved in reporting back in, and that's how I knew him back in the days of Cover Oregon, who on this exact issue. And when we first passed it, he called and said, "What was the conversation like? What was it like? You know, what is your thinking? What is the marketplace thinking? You know, how long is it going to take?" A whole bunch of questions, and so I referred him to Elizabeth, gave him a few, and I see she's not here today. And then when it was, when we got the letter of rejection or the letter of, "Gee, this is going to take a long time, and we don't know what you can do to help." Then he really wanted to know, well, what was the thinking of the group? I said, I don't speak for the group, and well, what do you think, and why are they doing this, and why can't they do this, and why can't they do that, and you realize how much money they're going to save, and who is it that's holding this up? And I referred him to Elizabeth, and then I haven't responded to his last 2 messages because I don't know enough to have to not say the wrong thing, to not make a mess. And I still am going to refer him to Elizabeth. But I'm more, I think I'm hearing that there actually is motion to move forward and not just, well, we have to wait till there's the governor has to decide about her big budget and things that look like we're being put off. And it doesn't sound like that now, but so I'm glad that you recognized that in other states it is the media does want to know, and the media does want to know here. So we'll just have to wait and see what we can learn, and what we as members of this committee might be able to do independently, because the state senator and state representative in my district are both very much interested, especially the state representative from my district wanted to know. And so I'll just tell them we're waiting to see.
Yeah.
Can I react to that?
Of
So,
course.
Jim, I appreciate you bringing that up because I think that surprises me that a reporter would be commenting that it would save the state money. I would think the reporter would be asking, what are you guys even thinking about doing this again? So I wonder when that gets in the public consciousness that we actually could save consumers money by moving more quickly.
Yeah.
I
Well, I think
wonder
they're
what
also
that would-
looking for controversy and conflict. You know,
Yeah.
that's knowing this particular reporter.
Well, because I think
don't we have something here we can.
that might help us.
Yeah, but it's a lot of money. It's a big difference, and it's Oregon versus something in Washington D.C. that we have very little control over. So that they can look. You don't know what angle they're going to take on it. So we need to have the best angle that we can put forward. We can't control what they're going to say, but.
Any other comments or questions? Anybody on the phone? All right.
I would just say, having had the chance to be part of this committee over the last 2 years and hear the conversation and all the research, even though I've sit in another agency, has been hugely helpful. I mean, I think I understand the business case and the numbers much better than I would have ever had somebody just brought the idea to me. And so, whatever that's worth, I think you guys have just done a great job of sort of evaluating this and thinking about it from every angle. I think it's definitely not work that's gone unnoticed or won't be used. I think you're really laying the groundwork, which will be really helpful down the road.
Appreciate how Victor supported that work.
So I just wanted to add, so I hear you all, and it's been a few years since we started this conversation. And I recognize your concerns, I recognize your suggestions. I think what's really come into light the last couple of years is that Oregonians see the value of health insurance. We see that in our enrollment numbers. They come back year over year. Yes, there's a slight decrease, but they come back. And I think what's really come more into light is that there are things we can do with the marketplace, with the exchange. So that's why we're taking a little bit more time to really be thoughtful and deliberate about the whole process, not just the process of the technology, but really where should we live so that we can best leverage what the exchange can do. I think there's a lot of potential, and we really need to think about every single thing, because innovation happens left and right, and there's states that can do a lot of things because they are a little bit more flexible. But I think it really comes down to what works for us, what can we make work for us, and if the marketplace goes to OHA or stays in DCBS, I think those are the conversations that we are having now. We're starting to have now, because it's not something that we want to take lightly. So I think I appreciate your concern, and I hear your concerns about it. Please know that we are moving as fast as we can while also being thoughtful and deliberate about the process. There's a lot of big things that we can do, and it'll take a little bit of time. So thank you for your suggestions, and I'm really, really happy that a lot of you are coming back for another term. So I think we have 6 or 7 who are coming back, and hopefully for Senate confirmation of February 5. So that's a reminder as well. So thank you for coming back for another term, because I think the conversation will continue to happen. So I really appreciate your time for that. So,
I just add one quick thing that Victor also worked through, and that's to speak about the things that can happen with innovation. Pennsylvania, for instance, is using the extra dollars that they're saving from the federal marketplace to actually fund a reinsurance program. So there's ways to appropriate those dollars and savings to even strengthen the market further. So that's just another thing that's happening in some of those states that are making that transition.
Thank you. Well, I assume that at our next, sorry, Jim.
I'm just, all of what you say is true, but what we're doing doesn't exist in a vacuum. The ACA, I've said this before, passed 10 years ago, and it looks, and we have certain political forces out there that are sucking all the oxygen out of the room, suggesting that if we just elect this one person, we're going to have universal health care and that are putting forth a vision that's not even close to accurate, but are creating notions in people's head. Meanwhile, what we're doing is making excuses for how much longer just this is going to take. And so I really think we need to have a message that looks positive, that says, these are our steps. Yes, we're moving forward. These are the things we're going to be able to do, so that we have some reasonable, some reason to give people hope beyond, especially when Medicare for All doesn't pass. That actually there are things that can be done, that we can make a difference, that we can be hopeful, and that there aren't just these two polar opposites for healthcare reform of Medicare for All or plotting between OHA and DCBS and the CIO or the various things that have to be done. But I want to see a positive vision for moving all that forward. I just think because it's going to be a problem as we get closer to November and after.
I was going to say, I'm assuming we'll have some updates at our next meeting, possibly some major updates as there's some conversations that are happening in the end of February.
Sure.
Excellent.
Yeah.
All right.
And just a parting thought, a lot of uncertainty, a lot of unknown timelines, and I hear exactly what you're saying, Jim. What we're doing is it's very easy to get frustrated and to get just kind of take your foot off the gas. We're not doing that in terms of development of this idea. So we're putting everything together as though it's going to happen next year, what have you, as quickly as can be done, and just have everything we can ready so that when the time comes, if somebody realizes, oh, that's right, we actually can't do this without our own state exchange, we'll be already ready to have something in hand. So we're not taking our eye off the ball.
We are. I agree.
Thank you, Victor. Yes, Joe.
I want to go back just a little bit to what Jim mentioned about the interaction with the media and kind of a public information aspect of this. I think it would be helpful for us as members of this committee if you would be able to help with some communication guideline for us. Just some high level, if somebody asks, this is what would be best to say or mention. You know, we're not going to go into details, of course, recognizing the sensitivity and, you know, things that we're still unsure of. But I think, you know, if we could ask staff if you would be able to just at least give us like 2-3 bullet points that we can, you know, say with confidence, this is where we're at. That kind of helps us as well to represent this committee well.
Thank you. We would be happy to do that and follow up with you offline after this meeting.
Awesome. All right. I think that wraps up that agenda item, and we'll move it on to Katie. Thank you.
While Don's getting my presentation up, hi, I'm Katie Button. I'm a plan management analyst. I certify the plans we sell on healthcare.gov, and I also managed the window shopping tool implementation. And so I'm going to give you a quick little update on how that went. It's okay. I love having Don and Victor to do all this stuff. I used to support the Oregon Health Policy Board a long, long time ago, and I was Don and Victor, and it's a really hard job, so I just extra appreciate them because I don't have to do these things. I get to sit here and just hold the clicker now. It's so great. So we released our tool officially on October 18th. And then we tracked, so open enrollment was extended for 2 extra days this year because of some issues with healthcare.gov. So we tracked our total number of unique users from the 18th of October to December 17th, and our whole number was 35,337, which we're really excited about. Our goal was about 28,000, so we exceeded our goal, which made us happy. And then the majority of users were in the Portland area, followed by Eugene and Bend, and then we had a variety of users in like random places like San Francisco and stuff like that. So I'm not really sure who was checking us out from San Francisco, but they seemed to enjoy it. So the average time on the site stayed pretty steady, about 7 minutes. So consumers logged on, they put in their household information, and then they went and browsed plans. And so we were able to get some information about the plans that consumers browsed. So there's 2 columns in this table. The first column is unique views, so that's every time a particular plan was accessed. And then the total views are every time someone went to look at a plan. So it may have been the same consumer looking at a plan 5 times. It may have been an assist or a community partner helping people, and they showed the same plan to different people 50 times. But so our overall unique views of plans are 60,000, and the total views were 95,000, which I felt was pretty exciting that people were actually really going out there and looking at the plan data. So the implementation was really easy. Victor was just talking about for the states that are looking at getting exchanges that now there's technology that's already there and you just kind of plug and play. And I had assumed that that was how it would be with Consumer's Checkbook, and it really was. It was great. They already knew all the data. They already knew how it would all function. And so transferring plan data, even though we had a pretty quick implementation window because of when we were able to do the contracting, like everything went up. We didn't have any major issues after the site was released. We did find one thing. We have a unique way of calculating tax credits for families who are above CHIP but still under the tax credit limit in Oregon because you have to include pediatric dental if the silver plans don't contain pediatric dental. And since not all of our silver plans contain pediatric dental, then for this small group of people, you have to add the silver plan premium. So this was something that I didn't even know was a thing until mid-October. And so by the time that I had figured it out with CMS and gotten all of the information I would need to tell Checkbook, we had already launched. Checkbook was like, okay, cool, we'll figure it out. And they're like, okay, we call healthcare.gov's API. But in the meantime, in case that ever goes down, we need to build our own database. So then they worked with me to just figure it out, how to like create their own database. So if healthcare.gov goes down, they have their own database. And then for next year, they're actually putting that functionality into the tool. So they'll load that data into the tool, and that will be native to the tool. We've gotten really positive feedback from users. The community partners have been really excited about it. They love that they can turn off that Medicaid eligibility and show people what their tax credits would actually be like. I've personally sat with a few members of the public and showed them how to use it, and they seem to really like it. So I am really looking forward to meeting with the community partners and getting their feedback and asking them what really worked, what were maybe some things we could tweak for next year, especially things around language, because we have the ability to edit all of the text on the site. And then we have some options. There were a couple of things that we didn't include this year. One of those was provider search, so sort of like provider directory information. It's about probably, I don't know, a third maybe of the actual information that carriers can provide in their provider directories, but you could still look and see, I see Dr. Jones, which plans cover Dr. Jones. The other thing that's a possible upgrade is formulary search, and so Checkbook is going to be adding a functionality to their tool, so you can say, I take X drug, and then they'll go out and search the formularies, figure out where it is on the tiers in each formulary, and then they will add it to the out-of-pocket costs, so you can see on each plan what that drug will cost you.
Nice.
So we're considering those, and then I just have a couple of other things tinkling around in my brain, like maybe dental plans, I don't know. So and a few other things that, again, I'll be conducting some stakeholder outreach to get people's ideas and feedback on what other things they'd like to see. So that is my very quick update. Are there any questions?
Any questions on the phone? All right.
Fabulous. Thank you.
Nice.
Made up a little bit of time, too.
I always
Thank
do.
you. I think next is going to be Anthony. Are you? Yeah. Thanks for being here. Thanks for your patience, too.
Yeah, of course. So I'm Anthony Behrens. I'm a senior policy advisor with Marketplace. And we're using this part of the committee for a rule-making advisory committee. These relate to our temporary rule that we passed last September, and it's so it's been in effect already since that time. Temporary rules expire in 6 months, so we either needed to let it expire or move forward. When we issued the temporary rule, there wasn't an advisory committee because those are issued kind of on an emergency basis, and so you don't need to do an advisory committee. The reason it was issued on an emergency basis is because that we realized we need to improve our rebating procedure, and we realized that a little bit too late to actually make the improvements via regular rulemaking. So we issued this emergency rule, and really it only affects carriers who have participated in the marketplace and are entitled to rebates. We did not hear anything from any of the carriers after we issued the rule. It did get a couple of questions from one carrier saying, why are we getting this money? That was easy to explain, but no concerns or anything like that. So the amendments that were made don't do a whole lot. The amendment to 945-001-0002 simply added a definition of biennium, and the reason we needed to define that term is because we use it in the other rule that we amended, OAR 945-030-0020. We defined biennium. I think we used a statutory definition that we found somewhere, but what we're trying to do is match the state's budgetary period. It ends up being a 2-year period beginning on July 1st of an odd year and ending on June 30th of the next odd year. The amendments to 945-030-0020 reduced the rebating period from 24 months to 12 months. So instead of rebating the money over a 2-year period, we end up consolidating that into a 1-year period. And instead of beginning almost immediately, we pushed the rebates out about 3 months to begin the January of the following year. So the January of the even year after the end of the biennium. So this year, rebates started January 1, 2020. And they go for a full calendar year, so 12 months. The first 11 months are paid in equal dollar installments, and then the last month is whatever is left over. So, for example, if a carrier was owed $1,100.98. They'd get $100 a month for 11 months, and then the last month they would get 98 cents. The reason we did it that way is just it's cleaner and easier for our accounting folks. So that was one of their requests. And then the last change that was made is a clarification that if a carrier drops out, so for example, we had a dental carrier decide not to re-up this year. So since this is the year we started rebating, their rebates, they're no longer entitled to their rebates. Their rebate actually will go back into the pot and be distributed to the carriers that are still participating. So we clarified the rule to make that more clear, more understandable. And if a carrier should happen, if the timing should be right, we just wanted to make sure that a carrier who didn't actually pay into the system wasn't going to get any kind of rebates. It's kind of impossible anyway based on the way it's calculated, but we just wanted to make that very clear. And again, in order to get the rebate, you have to participate. So those are the changes. I'm happy to answer any questions if there are any about the changes that we made.
All right. Any questions from anybody?
So what's the impact on state agencies, units of local government, and the public?
So those are questions that we actually do have to ask you guys, and so thank you for that, Jim. So I guess if you all have any ideas of what the economic impacts are to state agencies or government or the public, I'm happy to hear that. I will just sort of tell you that there's no impact to us or any instrument of government. There shouldn't be any impact to the public because the statute already says that we're going to rebate this money to carriers, and so carriers will be, I assume, reworking rates based on money they get back in rebates. But I'm happy to hear if you all have ideas that might.
So then I default to the carrier community. So it sounds like this notice went out to the carriers. They had a chance to review it, and there was little to no reaction to it.
Yeah, well, I haven't heard
questions.
other than those questions
Yeah.
I got when they started getting the money.
Okay.
There was no.
Sounds good.
Haven't heard anything. So I know.
There are no carriers that are small business, I assume.
Yeah, none
So
of the
that-
carriers are small businesses.
That doesn't apply.
No, and I'm thinking like an indirect impact. Like obviously, if there was some substantial impact to the carriers, that would inevitably trickle down to consumers and small business. So.
MLR sort of thing.
Yeah.
I mean, if we go below the MLR, is that?
Yeah, no, so it sounds like just the way you guys are going to be getting rebated changed a little bit, the timing on it, but it doesn't seem.
So yeah, the timing, you might get
Yeah.
a little bit more money because there's no question now that if a carrier is no longer participating, like that dental carrier I mentioned, that now the rest of the carriers will get a little bit more money, but it's not a lot of money.
I don't think
I guess that was going to be my question, is how material is it?
Yeah, it's I would determine as insignificant.
Okay.
Yeah.
Okay, sounds good. All right. Anybody on the phone have any comments regarding this topic? All right. And is there anything you need from us outside of just notifying us of this?
That was really all. We needed to have a discussion, and I didn't anticipate that there would be a lot. So
Okay.
I appreciate you letting us
Okay.
use you for that.
Sounds good. All right. Yeah, I think the last item is just looping back to cable, because I think you got cut short and we didn't get a chance to possibly ask any questions or have a little bit of a discussion about your presentation. So,
Shannon, I just want to comment, the meeting has moved along much better since Dan left.
So in addition to the data that was put on the slides, I do have small snippets of other data. If anyone had questions specific to any age bands, any FPL, I could give you some high-level a PTC and premium data. If there were any questions about that, I can say quickly, there was not a significant change in premium after APTC. It's $1 different last year for those folks who are receiving APTC. The APTC did increase about $9 over last year, so the average person getting it, there just wasn't a lot of change. The premiums were very stable this year, so.
Do you know anything, can you disclose anything about whether the percentage of people on subsidies changed?
It did. It is about 2.7% lower than it was previously. And again, I think that goes back to the way CMS did indexing for this plan year. So that changed the kind of threshold for APTC. And then as Katie's mentioned in our discussions, there was a couple counties, and I think you can probably pick them out. I think Kaiser was no longer the second lowest cost silver plan in a couple counties, and that really kind of changed the benchmark premium amount for certain people, which then made a subset ineligible to actually receive any dollar amount in subsidies. So that can have an impact there. Any other questions?
Yeah, I think the information was really good, although I'm trying to remember back. It's right at the beginning of the meeting, but I thought Dan mentioned or asked if you noticed. So you mentioned what's happened with 2020, but can you speak to any trends over the last 3 years or anything like that?
Trends over the last 3 years, and again, I can't speak specifically to this year yet because it usually takes until February for effectuated, but we have seen a higher percentage of people effectuating their plans.
That's good.
So that's good. That means that even though we're seeing a decrease in plan selections, those people who are selecting plans are probably more serious about actually going through and keeping, or at least starting out with the health insurance. Naturally, every year we see about a 15 to 20,000 enrollment decrease from January to December. People start out, people find out they're in relatively good health, they decide they don't need it. You get close to October, November, December when holidays come up and people are like, I want a couple $100 a month extra for gifts and holiday parties or whatever the case may be. That trend's held up. I was going to say, again, the amount of people on silver plans since the CSR rule went into effect, effectively ending the cost-sharing reduction payments to insurers and then having to do the loading of the silver premium has really demonstrated a lot of change going to bronze and gold plans. It's made it a much more, the consumers are getting more informed about that decision when they look at, okay, I might have this lower deductible or slightly lower deductible in the silver plan, but hey, I go to the doctor 2 or 3 times a year for a checkup or a physical. I think I can handle a bronze plan that's $200 cheaper a month because of the tax credits and the difference in the silver premium. Or you have the other end of that spectrum where a person's using their health insurance a lot more, might have some sort of condition, and they're getting such a small cost-sharing reduction subsidy that it makes more sense to then go to that richer gold plan and their overall cost of healthcare over the year. So I think that trend continues to show as we see in the last 3 years a shrinking share of those plan selections be silver plan selections.
So you actually think that's an informed choice that people are making?
I think so. I mean, I think it comes down to, and I think we've seen a continuous, every year 30 to 35% of the consumers that select a plan are using an agent. So agents are probably helping them make those same decisions, really sitting down and talking to them about what conditions they might have or how frequent they might use a doctor, and then saying, hey, I know that this plan looks like it's got a much lower deductible based on the cost-sharing reductions, but if you're really only going to the doctor 2 or 3 times a year, this bronze plan that you're only going to pay $15 a month for is going to be a better option for you over the course of the year. So, I mean, again, since I get just aggregate non-consumer level data from CMS and it's not great in how they send it to us, that's just based on those trends continuing that way and kind of feedback we've got from agents and other community partners who do have those discussions with the consumers. So based on the information we get from those kind of three facets, that's kind of the best hypothesis we have for why we're seeing that shrink in silver plans and increase in those other two metal tiers.
That's a really good message. I mean, you guys should take some credit for that.
Well, and I know Elizabeth on the marketing side has really, especially this year, Kaiser Family Foundation comes out with these $1 or no dollar. In other states, it's $0 bronze plans. And Oregon, obviously, with the non-EHB, mandates for certain premiums, there's always a little bit of a premium. But she worked with a couple of reporters and different media outlets to highlight if you make this range of money with this family size, you could have a bronze plan for $1 a month. And so I think that message really hits home and maybe captures some of those folks that have traditionally thought that I can't afford anything with the marketplace. And when they see, oh, wait, I might paying $20 a month for a bronze plan. And oh, look, because of our new bronze standard plans this year, I can actually go to the doctor and have a $50 copay for my doctor visit. I don't have to put it all towards deductible. It makes it a lot more feasible and a lot more practical. And again, that's just based on kind of the stuff we've been pushing, the feedback we get from like Shannon with some of her consumers. Until we have an actual way to put our hands on the enrollment data at the enrollee level and where they're coming from, where they're going, and their specific demographics, we'll never know for sure, but the data kind of supports that story.
Cable, what's you mentioned the disenrollment over the course of the year. What's the volume of special enrollment?
Special enrollment, the last 2 years has been pretty high because we had things that happened during open enrollment that allowed for special enrollment periods early on in the year. So we saw, because we market that to certain people, we saw a pretty big influx of SEPs in the kind of January, February timeline. But last year, I believe we had something like 30,000 special enrollment plan selections over the course of the year. And again, without knowing where people are coming from and where they're going, we don't know if that's setting losses by people that are moving to an employer-sponsored plan because they've got a better job, folks that are going to Medicaid, folks that just have decided they don't need their plan anymore for the rest of the year. We just don't have that knowledge, but and we don't really have a full knowledge on how many of those people effectuated those plans either. A person might get an SEP, might go through that process of selecting a plan and then just decide, I just don't want to pay this bill and not actually follow through, and we have no way of tracking that. Okay.
So my other favorite data point, Craig, the trend that I've seen throughout the years is that auto enrollments are going up every year. And this has become one of my favorite trends because when my visit to DC last year, there was a federal official who they were asking our thoughts on auto enrollment because they don't like it. They would rather folks go and actively shop. And I had to remind them that this is a consumer protection mechanism. Because if folks are happy with their health insurance plan and don't see any other option, they don't have to go through all of the steps. They can be automatically re-enrolled. And for them at that time, it was a surprise. But the data now shows that within all the states with auto enrollments going up every year, that folks actually like this feature. They're happy with their plans. They don't need to shop around if they don't have to. And they don't go without insurance at the start of the year. So that's become one of my favorite trends from the data sets that we have.
Do you have to actively select that you will be auto-enrolled, or do you default to auto-enroll?
Tax credit. It tells you that it will only auto-enroll you if you choose to be auto-enrolled, but it will auto-enroll you. So if you don't want to be auto-enrolled, this is part of why enrollment is high, but effectuation is not high, because people are like, oh, I'm going to such and such, I'm moving at the end of the year, like whatever, and they don't think that they need to go in and tell it not to auto-enroll them. And so that's why they'll term for non-payer. We've had cases we had one. A woman moved to New York and joined their exchange, and she had her MOTA payment going off on a credit card that she didn't use very often, and all of a sudden she's like, I've been paying this all year. And I was like, it's okay, let me call MOTA, let's prove you went to New York, they'll term you all the way back to the beginning, which is great, but it would have been nicer if healthcare.gov would have been like, oh cool, you chose not to auto-enroll, so we'll cut you off. So you do have to, that's one of the things we try to tell consumers, you must actively go in and stop that enrollment.
Okay. Yeah, I think there's a balance for sure on the auto enroll. And I think what you're identifying, Cable, is, I should know this more precisely, but I think because of the silver loading, and when silver gets smaller, because people are choosing gold and bronze, you have to load silver more, which has this compounding effect of the subsidy. You know, the APTC, I think, grows relative. So in theory, people should be moving. It should be more economical for people to move to gold and bronze over time. Just that dynamic of the silver loading. So I guess I wouldn't want people to miss out. And just auto enroll, because they might be just sitting in silver, but they could find a much better deal for them. So there's a balance in there.
Right, and I mean, and to just say that they were auto re-enrolled without doing anything, that's not the full story. These people might have gone in and actually browsed plans and looked through and updated some financial information. It only becomes a non-passive auto enrollment if they actively select a different plan.
Yeah,
so they can go, these people, a good majority of them may have gone through and actually given it good consideration to another plan, but when they didn't find anything they felt better than what they were currently enrolled in, they just let it passively enroll. So even though it does say a passive auto enrollment, we don't know how involved a person was in that. And I will say another trend that we've seen over the last couple of years is we're seeing a decrease in consumers actually requesting coverage on applications, but we're still seeing the share of people who select a plan is becoming more and more of that. So the people actually going through and using the website and looking for coverage, it seems to be a more serious group of people that are really more interested in the health coverage, whereas a couple years ago we had a massive amount of people who submitted applications requesting coverage, but a much lower portion of those actually selected a plan. So, the consumer, I think, is becoming more and more familiar with it, and the people that are actually using it have a higher intention of not just kind of going to see what's out there, but they're actually more inclined to look to get coverage if it's something that they feel that it can afford.
I was going to chime in. This, to me, feels like market stability. So for me, if my consumers can stick with the same plan and the same company year after year, that's a good thing, right? And that's because there's stability. It's not fun to have to redo everything every single year. And I'm sure for carriers, it's not fun to have everybody leave you and jump around, So I would say, to me, I would extract that this is indicative of more stability in our market, which is a really good thing.
And it was kind of a little bit of a surprise because with Pacific Source moving to some different counties, and I think MOTA moved into a couple more counties as well, we thought we might see a lower share of those passive re-enrollments with so many more options in certain areas of the state. But, even with that being the case, there was still a very high amount of folks that said, no, I'm good with this.
How did our numbers compare to national numbers or to, I know we have a few states that were in Victor's presentation as far as growth or losses, rather, for enrollment?
I think we were on the kind of, depending on how you want to look at the upper 50th percentile, we were above or below average. So we had a lower percentage decrease than many states did. Now, when you look at the national trend, sometimes that's skewed because states like Florida, which had a massive increase for whatever reason, and limited Medicaid and just their huge share of overall healthcare.gov can skew the national percentage. But when you look on a state-by-state basis, a 2% decrease was much lower than most states.
Nice.
And then with Medicaid expansion in a couple states, that made their decreases look even more large because so many more people were actually eligible, or less people were actually eligible to purchase through the exchange.
Awesome. All right. Any other comments or questions? All right.
Just one quick one on the auto enrollment issue. That is exactly the kind of nuanced conversation we hope to have in the future. Right now, it is just a giant on-off switch. So either, or because there may be room for nuance to be able to say, we'll auto enroll, but under these conditions, this happens. These conditions, this happens. We just don't have any of those options right now.
All right.
I assume if we own the system, we can also, we'd have track not only of, we'd be able to connect the two information you guys just provided, right? We'd be able to,
And I mean, theoretically, and I don't have
Make a recommendation.
a full grasp on what the other vendors offer, but I'm inclined to think that you could also look at an enrollment's application activity. So you could see if this person who passively enrolled or not actually went in and did any work on their application, which would give you a much better idea of if they were even considering other plans, if they looked at other plans, and then you'd have better backing data to say, oh, this person just really wanted to stay in this plan.
We could also see more like I see when I look at things. There have been years when I've had to choose whole new carriers for people to crosswalk into, and it's really awkward because I don't really know anything about. I make an assumption that they choose Kaiser or not Kaiser, and then basically pick the cheapest plan, because if you look at trends and enrollment and numbers as a whole, that's where it goes. But I have no idea of knowing if it's actually like that. Like maybe the people that are moving are actually not the same people. They're new people who but it looks like it's moving. So there will be a lot more opportunities for much more effective assumptions.
Yep.
Awesome. All right, thank you. Yes, Joe.
Yeah, I wanted to ask, you mentioned a few times how we can't get into like the demographics, like where's this 2% or the, down 3% for returning consumers with an active plan selection. Like we can't really get the demographics, or like where, in what counties can we say account for most of this percentage there change? Is there any hopes that we can get those numbers
From our CMS partners, I would say currently no. A different administration might have different thoughts on how a state that was working with them could use that data. But we've tried pretty tirelessly over the last couple of years to squeeze more and more data out of them and be able to share more and more data, because the stuff that I'm telling you right now is going to come out in March, but they won't let me tell you right now the exact same stuff that they're going to publish with the exact same numbers. And
But we will know it in March.
You will know it in March. I'll get you a full numbers to numbers thing so you can, see what my 3% change actually means by way of actual plan selections.
Yeah, I think just the implications of really getting good access to good numbers with, what Victor was also talking about, really understanding how we can tweak the system to be able to better, directly go at marketing in that, place or in that community as well, and thinking about how useful that is also for the public health aspect of insurance. That's very, very helpful information. But yeah, I hope these are things that we can really get to in the near future.
Oh, I'll push for them.
We hope to, Joe.
All right, thank you. Any last comments from anybody? Questions? All right. Is there any public comments? Anybody on the phone or anybody here who would like to make a public comment?
Star one for folks on the phone. If you push star one, you can speak.
All right. I think.
When's our next meeting?
So I believe, just a few housekeeping items. So for those that are going for reappointment, I believe you all received an email from the governor's office. I think it's February 5th. So looking forward, and I think because you were going up for reappointment, you're not required to attend.
I think that finally became clear.
But if you are, please let us know. We'd love to join you for your reappointment confirmation. Yes.
Did you get an email saying you had to be there?
No. It was just confusing, I think.
Yeah,
I got one
there was
from the
one that
staff.
says you don't, then there was one that says you do, then there was one that says ignore the most recent one, you don't.
Gotcha.
Okay, so if there's any help that we can give to clarify that, please let us know. Our next meeting is on April 16th. I already wrote down a couple of things that you requested as mentioned throughout this meeting. And we will definitely also provide you with the CMS public version of the data, so provide an updated version of our enrollment report and or provide additional information. And of course, we'll always email you ahead of time for call for agenda items as per our usual. I think those are the high-level housekeeping items for the committee. And looking at the team, the rest of the Marketplace team, if I missed anything.
I will say that what I can do prior to the next meeting, I'll get to Chicky the actual CMS data from last year so you can see what they report on. And then if you have any specific questions you want me to address for 2020, when that data comes out, I can come with those comparisons for you.
All right. I think that wraps us up. Thank you all for your time.
Thank you.